Welcome back. I think people can hear and see me properly. We'll be continuing with where we left yesterday on hepatology. We'll be dealing with acute liver failure and probably hepatitis today. So that's what we're going to talk about. So you all able to hear? I think there are 30 plus past participants already. So I think you must be able to hear. Thank you. Thank you, Sanju. Thank you, Vijay. Thank you, everyone. Yeah. For acknowledgement, let us start with our today's session on acute liver failure first. We have quite a few things to discuss as far as acute liver failure is concerned. First, the etiologies, especially people do ask me very commonly about the most common etiologies. But apart from that, we have a lot of other things to note in the first place. So whenever the patient is having an acute liver failure, first of all, yesterday, as I told you, what do you mean by an acute liver failure? In the sense, first, the timing is very important. So from the time of development of liver injury, which can be evidenced by maybe a transaminitis, increased liver enzymes, or probably even it could be jaundice clinically, or hyperbilirubinemia. From that time onwards, how fast you get the signs of liver failure. So liver failure means only two things. As I told you multiple times, you should have either encephalopathy or coagulopathy or both. So coagulopathy means if the PT is more than, or if I can talk about the INR, if the INR is more than 1.5 by definition, INR more than 1.5, or clinically defined encephalopathy, so which happens within a period of 26 weeks, or you can call it as 6 months, within a period of 6 months, whatever may be the case. So this is what we refer to as an acute liver failure in the first place. As I told you multiple times in the past, acute liver failure is the same as that of chronic, fulminant liver failure as well, or for probably fulminant hepatitis. So please tend to avoid the term fulminant in real life, even though old practitioners very commonly use the term fulminant again and again because they're very used to that particular term. But nevertheless, it's better to use the term acute liver failure rather than using a term like fulminant liver failure in the first place. And as far as etiologies of acute liver failure is concerned, they'll be asking you about the most common causes. Most common causes in India or any developing country is going to be the viral hepatitis. So viral hepatitis is going to be the most common cause of ALF in India. Specifically, if you ask one viral hepatitis that is extremely common in India that causes acute liver failure, that is hepatitis E virus. Even though the incidence of ALF with hepatitis E virus is quite rare, it is less than 1%. We'll be discussing about that in some time because there is one particular population called pregnant women, especially towards the third trimester, they get a higher rate of mortality and higher incidence of ALF compared to the non-pregnant population. So HIV related ALF in pregnancy almost touches 20%, whereas HIV related ALF in non-pregnant individuals is typically less than 1%. So it's very rare. So pregnant women are more susceptible for hepatitis E virus. And it's not HIV, it's hepatitis E virus, which is the most common cause of ALF in India, according to the NCDC data, that is National Center for Disease Control. They give the statement every time. So according to them, the viral hepatitis that most commonly causes ALF in India is hepatitis E virus, which has to be clearly known. Apart from that, if they specifically ask in children, in exam, you can go for hepatitis A virus. And specifically, if they ask in adults, once again, it becomes hepatitis E virus. This is a sort of a subdivision from what we have learned. But nevertheless, viral hepatitis tends to be the most common cause of ALF as far as developing countries is concerned. And India being a developing country, and viral hepatitis is the most common cause of ALF. But in the Western world, in the developed nations, probably where viral hepatitis is not endemic. So in that setting, you can think about a drug overdose, especially paracetamol overdose, or I can write acetaminophen is the most common cause of acute liver failure. As far as cause of ALF is concerned, I can write by a mnemonic A, B, C, D, E, F, and probably even up to H I can write. So as far as the A is concerned, A usually stands for acetaminophen, which is a very important cause of acute liver failure, acetaminophen. Apart from that, we have many other toxins. Other toxin that is extremely important is this Amanita phalloides, which is typically referred to as mushroom poisoning. And it can happen in autoimmune hepatitis also, but quite rare to happen in autoimmune hepatitis. Usually it will be an acetaminophen poisoning or probably a viral hepatitis, to be honest. As far as B is concerned, B maybe stands for hepatitis B virus, which can cause acute hepatitis as well. Sometimes it can be fulminant and can cause acute liver failure. So hepatitis B virus, and probably we can talk about a Budd-Chiari syndrome. Budd-Chiari syndrome. Fine. And the C stands for cryptogenic liver failure, or first we can write hepatitis C virus, which can cause acute liver failure, but it's quite rare, not extremely common. And at the same time, you can get with cytomegalovirus, which is one of the non-heterotropic virus, but still they can produce acute liver failure in patients who are severely immunosuppressed, like post-transplant individuals. We know that. And or third, I can write cryptogenic cause, which means we don't know the cause. Cause is obscure. Maybe you can call idiopathic as well. That's cryptogenic. That's the third C. And apart from that, we have hepatitis D virus. And usually we know that hepatitis D virus usually coincides along with hepatitis B virus. Hepatitis D virus cannot come alone. You need to have hepatitis B virus for hepatitis D virus to survive in the first place. Apart from that, we have some drugs which can cause, especially here the drug I mean idiosyncratic drug reaction. Idiosyncratic drug reaction. For example, you can think about a chloramphenicol, which can cause idiosyncratic drug reaction, so which can result in development of acute liver failure. And E stands for again hepatitis E virus, and at the same time a non-heterotropic virus that can cause liver failure is Epstein-Barr virus, again in immunosuppressed individuals, but apart from that it's quite rare. And F stands for fatty infiltration. Fatty infiltration. So whenever you talk about a fatty infiltration causing liver failure, I always think about a Reyes syndrome. Reyes syndrome. A second one, which is even more common, but both these disorders are very rare. But the second thing that is even more common that can cause liver failure by fatty infiltration is something called as AFLP. Very, very rare disorder, not a common disorder at all. Your HELP syndrome is much more common than AFLP. That's called acute fatty liver of pregnancy. That's a life-threatening disorder. Here, delivery should be almost immediate. You should treat this AFLP similar to that of eclampsia. At any stage of pregnancy, when the patient throws a fits because of eclampsia, you deliver the child. Even if it is 24 weeks or 22 weeks, you don't bother. Similarly, AFLP is also some sort of a thing where irrespective of the timing of the pregnancy, you have to deliver the fetus because the fetus is the reason why it causes these problems. So it's better to deliver the fetus as soon as possible. So that's what AFLP is, acute fatty liver of pregnancy. And you can get with some genetic causes. When you think about a genetic cause causing fulminant liver failure, that is acute liver failure, we can talk about the Wilson disease. So Wilson is very important in this setting. It's a genetic cause, but Wilson rarely causes fulminant liver failure, ALF, but still it can cause. It's not like it cannot cause. And finally, you have H, that means it's hypoperfusion. Hypoperfusion means we're talking about an ischemic hepatitis. I told you there is a term called ischemic hepatitis called as a shock liver. I talked about that. At the same time, you can get with non-heterotropic virus, HSV, typically immunosuppressed individuals, which can cause hepatitis and acute liver failure, even though it's quite rare. And you can get in patients with HELP syndrome, which is again quite rare. Or very, very rarely, you can get in another disorder called HLH. That's called hemophagocytic lymphohistiocytosis. Remember, nevertheless, even though so many causes I have told you in mnemonic A, B, C, D, E, F, G, H, but there are few causes which are extremely common, like your acetaminophen, then probably Budd-Chiari to an extent, you can think about that. But hepatitis C, hepatitis B and all is extremely rare. And you can get with hepatitis A virus. I mean, I didn't write A, isn't it? So hepatitis A virus can cause. So hepatitis A virus is common. Hepatitis E virus is quite common. And what else is common? Maybe this ischemic hepatitis probably to an extent is common. Apart from that, other viruses causing acute liver failure is extremely rare. I mean, even though we put on table, we have cases that have been described, but still it's going to be extremely rare. But on the other hand, among all the hepatotropic viruses, hepatitis A, hepatitis B, hepatitis D, hepatitis E, so usually things that cause is the hepatitis A and D. Hepatitis C virus is something that is again extremely rare. You don't really get liver failure with hepatitis C virus. So that's asking hepatitis, anti-tubercular drugs. I mean, we already discussed, I think I put something on drugs here. So that drugs will include all the drugs. I mean, we have a separate entity called drug-induced liver injury that's called a DILI. Even though that is not important for exams, literally any drug can cause a DILI. It's not like only a particular drug is going to cause it. Any drug literally can cause a drug-induced liver injury. But there are higher propensity with certain drugs. So you have a separate list in certain websites in the internet which drug is having higher propensity for causing a drug-induced liver injury. You have tons of drugs. So that's why I've told you, like, you don't want to tell any specific drugs. You just call D as drugs. Literally, so many drugs are there which can cause a drug-induced liver injury. And there are many sub-classifications according to acute liver failure is there, but I don't think those sub-classifications really make any sense. For example, acute liver failure is further divided into something called a hyperacute liver failure, then an acute liver failure, and again we have a subacute liver failure. So these are subdivisions based on the timing. These are old classifications of acute liver failure, old classifications where we didn't know about how to classify an acute liver failure. Currently, it's very clear. The only definition of ALF is jaundice to liver failure timing is less than 26 weeks. That's all. So that's the only thing that you need to know as of now. But this is an extremely old classification, hyperacute, acute, and subacute liver failure. As far as timing is concerned, you can split the 26 weeks into 3. Like within a week, if it happens, within, maybe I can write 1 week, within a week, within 7 days, within a week it happens, it's hyperacute liver failure. Within 1 to 4 weeks it happens, it is acute form of acute liver failure. And if it happens from 4 to 26 weeks, we call it as a subacute liver failure. So this timing, again, right now it's not important, except for the fact that sometimes hyperacute liver failure and acute liver failure may have a better prognosis compared to that of the subacute forms of liver failure. For example, if you talk about the prognosis is okay. Got prognosis here. In the sense, I cannot tell good or I cannot tell bad. So prognosis is a little guarded in patients who are developing a hyperacute and acute forms, but subacute forms invariably have a poor prognosis. Similarly, when somebody asks you about ALF versus chronic liver failure means when the liver failure happens beyond 6 months, we call it as a chronic liver failure. So if somebody asks which one is having okay prognosis, I'll always go for acute liver failure, because chronic liver failure invariably has a poor prognosis, which means they are going to definitely end up with a transplant. Without a transplant, they die, because anything that happens slow and steady for a longer period of time has a more chance of having a sustained liver failure, and they don't survive without a transplant. So chronic liver failure is actually more bad compared to acute liver failure. Acute liver failure, if it recovers, the patient might be completely okay after that episode, but chronic liver failure is not like that. So it is a sustained injury and it's a sustained damage to the liver that is happening for a long period of time. So which means that damage is going to long last and the patient won't really survive without any further transplant. I mean, in the sense, like at some point they will be needing a transplant. But in acute liver failure, it's not like that. They might do well even without a transplant sometimes. And once the ALF episode is recovered, they might not even get that liver injury again, or the liver might completely recover back to normal. So that's why ALF, I feel, is okay compared to that of the CLF. But only thing is you have to survive that ALF episode. That's the most important thing. As far as coagulopathy is concerned, remember, coagulopathy is more serious and more severe the faster you get the liver failures. The more faster you get, the coagulopathy is going to be more serious. And typically your encephalopathy, cerebral edema, raised ICP, all these things are going to be more serious the more faster you get the liver failure, which means when a patient is coming with the chronic liver failure, the coagulopathy and encephalopathy may be there, but it will not be that serious and will be very subtle most of the times. Or they might not have any encephalopathy, or they'll have very little coagulopathy evidenced only by an elevated INR, but apart from that, everything might be fine in a chronic liver failure. But in a patient with an acute liver failure, the defining features are this coagulopathy and encephalopathy only, especially patients who are developing this faster liver failure, like hyperacute liver failure. They might go for encephalopathy so fast that they'll go for cerebral edema and raised ICP and they will die because of that. As far as jaundice is concerned, contrary to the popular belief that early will cause more jaundice, no, actually the more later you get a liver failure, like chronic liver failure patients have more jaundice compared to that of the very faster acute liver failure patients, which means the hyperacute is the one that has the least jaundice, followed by your acute forms of acute liver failure and subacute forms of liver failure. In fact, the chronic liver failure will have more jaundice compared to acute liver failure. That's what you need to take. And at the same time, if you ask about the survival means we are talking without a transplant. Survival without a transplant is approximately 35% here. Survival without a transplant is approximately 10 to 20% here. Survival without a transplant is only 10 to 15% here. So the more faster you get a liver failure, actually there is a better chance to survive without a transplant. But if you take a chronic liver failure, there is almost 0% chance you don't really survive without a transplant. At some point of time, you really need a transplant. Even though the patient might be okay for a longer period of time, but overall they will be needing a transplant, which means the chance of recovery of the liver is going to be very poor. If you're going to have a chronic liver failure, the chance of recovery of the liver from injury will be better in patients with acute liver failure compared to chronic liver failure. So, even though I've told you so many things here, this is not at all important because it's very old, and only if somebody asks you an exam, like I believe there must be a really old exam. So they don't really ask this. What we need to know is this much only. So what are the causes of acute liver failure, and what do you mean by acute liver failure, and what's the most common cause of acute liver failure in the world? So that's what we need in the first place. As far as treatment of acute liver failure is concerned, treatment is quite easy. So you need to treat the cause in the first place. The two most important problems as far as acute liver failure is concerned is the encephalopathy and the coagulopathy. So these are two things you need to manage because these are the ones that are going to kill the patient. Apart from that, we have liver transplantation also. We'll talk about that. But encephalopathy and coagulopathy is something that are going to be very, very prominent in acute liver failure patients compared to chronic liver failure, and they'll be more serious in acute liver failure compared to chronic liver failure. It's like what we spoke in cardiology. Cardiology, I told you, the more faster and acute you get a problem, the more dangerous it is because acute things are very difficult to handle by the body compared to chronic things. So that's why they develop faster encephalopathy and a faster coagulopathy, and it will be more serious. As far as encephalopathy is concerned, typically we are going to manage lactulose, and at the same time we can manage with probably plus or minus phosphate enemas. Lactulose and phosphate enemas, this is how we're going to manage. Apart from that, other standard encephalopathy management is there, like rifaximin. We'll be discussing in greater depth and detail when you're talking about cirrhosis and a chronic liver failure and problems regarded to portal hypertension. As far as coagulopathy is concerned, we are going to use IV vitamin K plus or minus FFP. Remember, FFP should be avoided unless and until there is some real indications to give an FFP because FFP sometimes can result in severe volume overload. So somebody asks you what are the universal indications for FFP. One is active bleeding. Active bleeding plus INR more than 1.5. So that's indication number one where you can give FFP. Second is you are planning for some invasive procedure or some interventional procedure planned for a procedure. Plus if your INR is more than 1.5. So even without active bleeding, if you are planning for a procedure, plus if INR is more than 1.5, you can give FFP. Or if you are not planning for a procedure, but the patient is having active bleeding plus INR more than 1.5, you can give fresh fluorescent plasma. Apart from that, there is no real indication for FFP. But based on fibrinogen levels, you can give cryoprecipitate also. But I don't think in acute liver failure patients, the fibrinogen levels will be so low to give cryoprecipitate unless and until there is a coexisting disseminated intravascular coagulation. But if the target fibrinogen is to maintain at more than 100, so if it is maybe less than that, then maybe you can prefer cryoprecipitate. Other than that, I don't really precipitate. I prefer using a cryoprecipitate. And platelet, again, universal indication is whenever there is a bleeding and less than 20,000 platelets, then you can give, or in 20 to 50,000 plus if there is a risk of bleeding, you can still give platelets. But the idea is to maintain the platelets at around 1 lakh. So that is the usual buffer. So 1 lakh is more than enough most of the times. But again, it depends on what is the disorder that you are basically dealing with. That has been discussed extensively in the hematology section itself in the app. So you can go back and learn. So where to give platelets and where not to give platelets. Platelets typically we use if less than 20,000, and definitely you're going to give platelets, no doubt about that. 20 to 50,000 with risk of bleeding or probably active bleeding is there, then you can give. More than 50,000, again, it depends on the disorder you're dealing with, whether you are going for any procedure or when you're not, it's a major or a minor procedure. Depending on that, more than 50,000 you might give, but usually you don't need. 20 to 50,000 you can give, for if there is any active bleeding or planning for a procedure. Less than 20,000, usually we go for giving the platelets, but the threshold is completely different with a particular disease type. So we don't want to know, talk about that right now. So nevertheless, these are the two things that you're going to deal with. One is encephalopathy and second is coagulopathy, which is extremely important as far as acute liver failure treatment is concerned. And second thing that we need to do is management of cerebral edema and raised IC, because many of these patients will have cerebral edema and they will have raised ICP. Remember, the risk is extremely high whenever the grade of encephalopathy is 3 or 4, because we know we have 4 different grades of encephalopathy, 1, 2, 3, and 4. But in patients who are having grade 3 and grade 4 encephalopathy, the risk is extremely high for getting severe cerebral edema and raised ICP. We know what are the signs of raised ICP. We don't want to discuss again. We have discussed in neurology with regards to the triad of raised ICP, that is Cushing's triad, hypertension, bradycardia, and altered respiratory pattern. And so whenever there is one logical rule is there, whenever you are having a acute liver failure patient, and if this patient develops hypertension, if this patient develops an elevated BP, this is always due to raised ICP, and there is a cerebral edema always there. So this is a rule in acute liver failure patients. Whenever a patient with ALF develops a hypertension, it is raised ICP unless proved otherwise. That's all. This is a rule. Usually they don't develop hypertension. If there is hypertension in a patient with ALF, it is raised ICP unless proved otherwise. So most of the time, raised ICP can be managed with conservative measures itself. You have to start with conservative treatment. For example, I think I've discussed about the traumatic brain injury management in the neurology, where you do typically the head end elevation. You can do that, no problem. You can use some hyperosmolar agents like mannitol or 3% NaCl. Typically, you prefer mannitol, but you can go for 3% NaCl also. And you can use hyperventilation. And you can use phenobarbital to induce a barbiturate coma. So it's an intentional therapeutic coma that we induce. That's called a phenobarbital coma. So we can induce a coma through phenobarbital. That is to reduce the cerebral metabolic rate. But make sure in liver failure patients you avoid benzodiazepines and any other sedatives. Sedatives and benzodiazepines should be completely avoided. Especially this benzodiazepines is something that has to be avoided in a patient with liver failure, because benzodiazepines traditionally and ancillary views that they are associated with the higher risk of encephalopathy. That's why you should definitely avoid benzodiazepine. There is no indication to give benzodiazepine. So do not use benzodiazepine in a patient with any form of liver disease or any form of liver failure, especially. You don't give benzodiazepine. Plus or minus, you have other treatment options which are experimental that can reduce the ICP in patients with liver failure to an extent. Like for example, you can use an epoprostenol, which is a prostacyclin analog, and you can use N-acetylcysteine, mucomist. So these are other measures which can reduce the ICP, but not that effective or only experimental in nature. But most of the times, in many of the centers, head end elevation and mannitol, and probably to an extent hyperventilation is alone more than enough. Maybe you can try a phenobarbital. That's all. But this is the most important point. Avoid benzodiazepines and any other sedatives in patients with liver failure, including acute liver failure. All right. So what are the targets? Suppose if somebody asks you what is the target that you want to maintain, in patients with raised ICP, typically the first target is the cerebral perfusion pressure. This is the same as that of the traumatic brain injury also, where I need to maintain the cerebral perfusion pressure of more than 50 to 60 millimeters of mercury. This is the target. And second one is the ICP target. The intracranial pressure should be maintained to less than 20 to 25 millimeters of mercury. Remember, the more the cerebral perfusion pressure and lesser the ICP, it's always better. So you know the formula for cerebral perfusion pressure, it is nothing but MAP minus ICP. So this is the formula for cerebral perfusion pressure. Normally itself, your brain tends to maintain the cerebral perfusion pressure because whenever your ICP rises, your CPP automatically will fall. So to avoid this fall in the CPP, your brain tries to increase the MAP. That's why you get that hypertension as a Cushing's response. And that is to maintain the cerebral perfusion pressure. So that is why you also, by treatment, you have to try to maintain that MAP and reduce the ICP so that the cerebral perfusion pressure is maintained at least more than 50 to 60, which is the target in many raised ICP conditions, not only acute liver failure conditions. And third thing that you need to manage is the renal failure that can happen in certain cases of acute liver failure, especially it's quite common in patients with acetaminophen toxicity. Either it can be a de novo renal failure due to some drug toxicity, or you can develop renal failure due to something called a HRS, hepatorenal syndrome. So possible, or it could be a de novo renal failure due to some particular insulting event itself. For example, if a patient is having ischemic hepatitis and ALF after a cardiac arrest, that cardiac arrest would have caused an acute tubular necrosis. That's different. Similarly, a patient who's having a paracetamol poisoning can have renal failure because of paracetamol itself, or a patient who's taking any other drug would have caused a renal failure because of that particular drug itself. So that's what I mean by a de novo renal failure, because of the particular insulting cause. In that, you have to treat the cause. So that is the most important. Suppose if you have a hepatorenal syndrome, then the best treatment for hepatorenal syndrome is terlipressin with albumin. Everyone knows that. So this is the most important treatment of hepatorenal syndrome, the details of which we'll be discussing in a short time. So that is terlipressin with albumin is the treatment usually that we give for hepatorenal syndrome patients. Alternatively, you can try CRRT, continuous renal replacement therapy, because these patients will be in ICU, of course, and ICU, the choice of renal replacement therapy will always be a continuous renal replacement therapy. Intermittent hemodialysis is not very good for this kind of patients, where they will not be really oriented. Encephalopathy usually will be very severe. And apart from that, you might be needing to treat infections by giving prophylactic antibiotics plus or minus antifungals, because these patients are at extremely high risk of infections as well. Typically in our hospital, in patients who are coming with acute liver failure, we generally give cefotaxime or ceftriaxone with the fluconazole. This is the usual regime that we give. That's a very common regime. And if the patient is going for respiratory failure, then you might be needing to intubate the patient. Especially if the patient is having a grade 3 and 4 encephalopathy, then the indication for intubation, the incidence of respiratory failure is very high. So in a patient with grade 3 and 4 encephalopathy, you can automatically qualify for intubation. But even though we don't do in many times, in practical scenarios, but guidelines suggest that if the patient is having grade 3, 4 encephalopathy, it's better to intubate and treat them, because they're at higher chance of developing respiratory failure. And second thing, last but not the least, is hypoglycemia, which is very, very common in patients with ALF as well as ALF patients, because liver is the principal thing, organ that maintains the fasting glucose levels by promoting gluconeogenesis. So if the patient is not having gluconeogenesis, they might go for hypoglycemia, which can be managed with continuous dextrose infusions. So these are the supportive treatment that we are going to give. So till now, whatever I have told is for encephalopathy, coagulopathy, cerebral edema, raised ICP, renal failure, prophylactic antibiotics, respiratory failure, hypoglycemia. All these things are supportive management. But apart from that, you need to give some disease-specific management. This is too much for you, but still there are some disease-specific management, because depending on what disease you're dealing with, you need to treat accordingly. Let me tell you in a easy way. Just one-liners. So for example, if you have drugs that are causing problems, like for example, if you have acetaminophen causing problem, we know that disease-specific management here, it is N-acetylcysteine. Always, if you have an idiosyncratic drug reaction, like for example, a chloramphenicol or a valproate is causing liver failure, in this setting, withdrawal from the offending drug will definitely cure the problem. So that is the most important treatment. As far as Amanita phthalates is concerned, because you can write toxins also. As far as Amanita phthalates is concerned, usually you'll have a history of mushroom poisoning. In this, the usual treatment for Amanita phthalates is penicillin G. Silymarin works to a great extent as hepatoprotein, plus or minus they might be needing hemodialysis also, because usually it causes renal failure as well. So N-acetylcysteine, withdrawal from the offending drug, as far as Amanita is concerned, you can give penicillin G, which works for Amanita, along with Silymarin, which is hepatic protectant. Along with, you can try hemodialysis if the patient is having associated renal failure. As far as virus is concerned, we are talking about hepatotropic virus first. As far as hepatotropic virus is concerned, Vijay is asking NAC infusion to give at 150. No. NAC, we have not talked about that. We have a separate topic on acetaminophen poisoning, which will be discussed later on. So right now, I'm just telling how to manage each and everything easily. So this we have not even touched right now. So I'll talk about that later on. And Vijay is also asking, is there any definition for acute on chronic liver failure? Yes, a patient who is having a chronic liver failure develops an episode of acute liver failure within a period of 1 to 26 weeks. That is again an acute on chronic liver failure. That's all. This is what we refer to as an acute on chronic liver failure, and that's quite simple. And again, a patient who is having a encephalopathy, already previously, or worsening of encephalopathy within a short span of time, again you can call it as a acute and chronic liver failure. So there is no standard definition, but we'll come back to that. Once you know about the chronic hepatitis and chronic liver, we'll be knowing that better. But as far as the hepatotropic virus are concerned, we have hepatitis A virus and hepatitis E virus, where we are going to give only supportive management. There is no role for antiviral drugs as far as hepatitis A virus and hepatitis E virus is concerned. And we have hepatitis B virus, acute hepatitis B virus, especially if the patient is having ALF, you are going to use tenofovir or entecavir. Any one drug you can prefer. Suppose if the patient is having HIV or HIV. In that setting, suppose the patient is having hepatitis C virus, we don't know how to treat. I mean, usually it is very rare. You don't get an acute hepatitis C virus causing acute liver failure. This scenario I have never encountered. Literally, HIV to an extent we have seen. HBV also we have seen 1 or 2 cases, but HCV is something which is extremely rare, and I don't know really it is there or not in the first place. HCV definitely won't cause acute liver failure. It is known for its chronicity, cirrhosis, and hepatocellular cancer later on in the life. So it's very rare, and nobody knows really whether to give antivirals or whether not to give antivirals. We can give if you want, but I don't think so. So, but nevertheless, your acute hepatitis due to any cause, maybe A virus or E virus or C virus without liver failure, you only use supportive treatment. That's all. So even with acute hepatitis B virus, if there is no liver failure, you are going to use only supportive management. Only if hepatitis B virus is associated with acute liver failure, then only you are going to give tenofovir or entecavir. We'll talk about that in detail in some time. Then we have non-hepatotropic viruses, which can cause ALF, very, very rare. Typically, you can get with herpes simplex virus. We know what we are going to do with herpes simplex virus. We are going to use acyclovir as the main therapy. Suppose if the patient is having a cytomegalovirus, we know what to use in post-transplant individuals. We are going to use ganciclovir or probably valganciclovir as a major therapy. If the patient is having Epstein-Barr virus, it's not CBV, it's EBV, Epstein-Barr virus. In this setting, I can use acyclovir once again. Plus or minus steroids will be usually beneficial for patients with Epstein-Barr virus. Suppose the patient is having parvovirus B19, rare but still can happen. Usually only use supportive management. Suppose the patient is having adenovirus, only drug that is effective for adenovirus, partially at least, is cidofovir. So these are the treatment options for non-hepatotropic viruses causing acute liver failure. But it's very rare scenario. You don't really get these kind of things in the scenario. Or you can get some autoimmune disorders causing issues, like for example, the most important autoimmune disorders, autoimmune hepatitis. Rarely it can cause a fulminant liver failure, that is acute liver failure, where you can use prednisolone plus or minus azathioprine is the major treatment for autoimmune hepatitis, even for patients who are suffering from other forms of autoimmune hepatitis. Or you can have metabolic disorders. As far as metabolic disorders is concerned, Wilson is the most important here. Wilson disease is the most important here. As far as Wilson is concerned, we are going to treat with copper chelators like dipenicillamine or trientine, along with we can use zinc. Plus or minus I can use plasma exchange. In acute fulminant Wilson, plasma exchange is supposed to be beneficial by certain trials, but again, it's questionable whether it's beneficial or not. That is to remove the copper from the blood, but nevertheless, it is something that is experimental again in acute fulminant Wilson. As far as AFLP patients are concerned, I told you the only thing that you need to do is emergency delivery, expel the fetus out. That's the most important. As far as HELP syndrome causing ALF, again, you know what is the treatment. You are going to do delivery, or any pre-eclampsia or eclampsia causing ALF. Once again, the treatment of choice will be delivery. There is no doubt about that. As far as Budd-Chiari syndrome is concerned, which is hepatic vein thrombosis causing ALF, here I'm going to use an IV heparin because it's a thrombus. That's the most important. As far as sinusoidal obstruction syndrome, there is something called a SOS, that's called a sinusoidal obstruction syndrome. As far as sinusoidal obstruction syndrome is concerned, it happens in post-transplant, especially after a bone marrow transplant. It can happen. One of the important complications of a hematopoietic stem cell transplant or a bone marrow transplant. So here, one important drug is there that is supposed to be beneficial. That's called defibrotide. So this is supposed to be beneficial, but this could be a question for your exams as well. They ask you a patient who's having a sinusoidal obstruction syndrome. The typical history will be in a post hematopoietic stem cell transplant scenario where you get a liver failure. It will be typically due to SOS, sinusoidal obstruction syndrome. For SOS patients, you can use a drug called defibrotide. I have not seen in my reality this drug used, but in advanced transplant units, because I worked in 6 months in bone marrow transplant, I have not encountered this case of SOS till now. But maybe once you encounter, you can. This is only theoretical. This is something which I don't know right now, which means in the sense I have not used it, just only a theoretical knowledge as far as I am concerned. So defibrotide is something that can be used in patients who are having a sinusoidal obstruction syndrome. And as far as infiltrative disorders are concerned, because a lot of infiltrative disorders can produce problems like malignancy or amyloidosis. So malignancy, you're only going to treat with chemotherapy or amyloidosis, because most of the times only AL type of amyloidosis, that is multiple myeloma, that is the one that is going to cause a lot of problems, including hepatosplenomegaly. So chemotherapy is going to the mainstay for infiltrative diseases. If you don't have any cause, it's the cryptogenic cause. If you don't know what is the cause, then probably you can try with N-acetylcysteine, which is currently approved for any other cause of ALF apart from your routine paracetamol poisoning. Similarly, in idiosyncratic drug reactions causing ALF, even here N-acetylcysteine has been approved. Even if some other drug is causing acute liver failure, guidelines are suggesting to use N-acetylcysteine. This is a very new thing. 2018 is where this protocol came, where many studies have shown some borderline benefit in N-acetylcysteine, even if the liver failure is not due to paracetamol or a non-paracetamol drug causing liver failure. There also N-acetylcysteine may be beneficial. That's what the guidelines are telling, and that's what the trial results are about. And even cryptogenic liver failure, if you don't know what is the cause, still indeterminate cause of liver failure, there also you can, as a benefit route, you can use N-acetylcysteine, not a problem. So these are the different specific treatment options as far as acute liver failure is concerned, treatment is concerned. And there are a few things that I wanted to stress about, but most importantly, I will talk about defibrotide if I am the examiner, because this is something students might not know. So that's why I stress on the defibrotide part. So which is used in sinusoidal obstruction syndrome, and which typically happens in the post hematopoietic stem cell transplant scenarios. And apart from that, you can do liver transplantation as well. You can do liver transplant also in patients with acute liver failure. So what are the indications for liver transplantation? So it depends on whether the patient is having an ALF due to acetaminophen poisoning, or the patient is having ALF due to non-acetaminophen poisoning. So this is what we refer to as a King College criteria. We have many different criteria also there, but King College is the one that is generally followed, and that is the one that is asked in exams as well. So as for the King College criteria is concerned, you can split it into: one is ALF due to paracetamol overdose, acetaminophen, or if it's a non-acetaminophen ALF. Non-acetaminophen acute liver failure. As far as ALF due to acetaminophen is concerned, the single most important reason for doing a transplant in these individuals is admission pH. At the time of admission, if the pH is less than 7.3, or if the serum lactate is more than 3.5, despite adequate fluid resuscitation. You have given a good amount of fluid resuscitation. Despite good fluid resuscitation, if the pH is consistently less than 7.3, or if the equivalent serum lactate is more than 3.5, so in that scenario, you can go for a liver transplant. This is the number one and the most important indication as far as paracetamol poisoning is concerned. Paracetamol poisoning typically produces a hagma, or probably produces a nagma. So what paracetamol poisoning does? It produces a hagma or it produces a nagma? The question is for the audience. It produces a high and-gap metabolic acidosis or a normal and-gap metabolic acidosis? Yeah, we have discussed that already, isn't it? In nephrology, we have discussed that extensively. It produces typically a hagma, That is because of one important metabolite called oxoproline metabolite. We have studied there is a mnemonic called gold mark for paracetamol poisoning. In that, O stands for oxoproline metabolite that comes in paracetamol poisoning, which typically produces hagma. And you can get a nagma also in certain patients, but nevertheless, in exam, if they ask you paracetamol poisoning, always go for a high NCAF metabolic acidosis. So that's what we usually do, but it can cause both hagma as well as an nagma. Or if suppose the patient is not having this indication, then there is a second indication where you need to have all 3 out of 3, whatever I'm going to tell. Number one is the patient is having a grade 3 or 4 encephalopathy, or the patient is having severe coagulopathy, evidenced by PT more than 6.5, INR more than 6.5, or an equivalent prothrombin time more than 100 seconds, which is usually equivalent to INR of more than 6.5, or the patient is having AKI, severe AKI, especially evidenced by serum creatinine more than or equal to 3.4 milligrams per deciliter. So all three, if it is there. So grade 3 for encephalopathy, INR more than 6.5, severe AKI, all these three are there. Then in this setting, you can think about a liver transplantation. So single most important indication is acidosis despite fluid resuscitation, or remaining all 3 out of 3 is there, then you can go for a transplantation in this scenario. As far as non-acetaminophen acute liver failure is concerned, the single most important indication is INR more than 6.5, that is severe coagulopathy plus encephalopathy of any grade. It could be even grade 1, doesn't matter. This is a single most important indication as far as a non-acetaminophen poisoning is concerned. Or if 3 out of 5 is present. So there I told you 3 out of 3, but here if I'm going to tell 5 points in that, if 3 out of 5 is present. So we can remember the mnemonic ABCD. ABCD means first age, that's A for age. Age is less than 10 or more than 40. Second one, B stands for bilirubin. The total bilirubin is more than 17.5 milligrams per deciliter. Remember, in any disease, in any condition, let it be alcoholic hepatitis, let it be a patient who's having a cirrhosis, or let it be a patient who's having a graft versus host disease, let it be a child pook scoring, let it be an ALB scoring. So whatever may be the scoring, when it comes to liver, the total bilirubin is very, very important. More the total bilirubin is, poor is going to be the prognosis. That's all. So every single scoring system will use total bilirubin. I mean, when it comes to the liver, even if you take your SOFA score, you would have studied something called a SOFA score. You would have known about that. Let me go back. Where is that? You would have studied something called a SOFA score, isn't it? That sequential organ assessment score in sepsis. Even in SOFA score, the total bilirubin really is very important. So the final take-home point is, in any condition, maybe a systemic condition or a localized liver condition, the one thing that tells you the overall death risk is the total bilirubin. So it doesn't only tell you the liver prognosis, it tells you the overall death mortality risk also. Like how I told you, irrespective of the condition, your acute kidney injury in ICU is a risk of mortality. Similarly, irrespective of the underlying condition, your total bilirubin is always a risk. I mean, it's a predictor of mortality. The more the total bilirubin is, worse is the mortality. Similarly, any ICU patient with AK or any hospitalized patient with AK is an independent risk factor for mortality. Similarly, the total bilirubin is an independent risk factor for mortality, irrespective of the underlying disease that is present. So that's what you need to know. Similarly, that's why I told you that bilirubin is very, very important here. So if it's more than 17.5, or the patient is having severe coagulopathy, not very severe like what we have seen, INR more than 6.5, but here INR more than 3.5, or an equivalent PT more than 50 seconds. Fourth is D. For D stands for duration. So if the duration is acute or subacute, it's not hyperacute. Hyperacute generally tends to have an okay prognosis, but if it's more of a subacute liver failure or acute liver failure, so it's not hyperacute. That's what I mean, but not hyperacute. Hyperacute generally tend to do well even without a transplant. But if it's not hyperacute, if it's a acute form or a subacute form of liver failure, then you might need to do a transplant. Etiology. E stands for etiology. Etiology, if it's an idiosyncratic drug reaction. Idiosyncratic drug reactions generally have a poor prognosis. So if your etiology is an idiosyncratic drug reaction. So in these situations, you might be needing to do transplant, but here remember 3 out of 5, if it is there, you can do a transplant. But in exam, I don't think they will complicate that much. The number one point that you need to know is paracetamol poisoning, ALF, indication for liver transplant. This is the number one point that usually asked in exam. The number two point is this one. They might ask these things in exam, especially the severe AK definition they might ask. So as far as paracetamol poisoning is concerned, what becomes the indication for doing liver transplantation? Maybe the number 3 point you can remember this, but I don't think this they will ask in exam. So no need to remember the last one. But these 3 things, if you know, that must be more than enough for exam. These are the indications for liver transplantation. This is the King's College criteria. There are many different criteria there, but for exam, just know the King College criteria. Especially the number one point is the paracetamol poisoning indication. pH less than 7.3 or lactate more than 3.5 despite adequate fluid resuscitation. If they ask you the prognostic indicators, what determines the prognosis of a patient with acute liver failure? The strongest predictor of prognosis in patients with acute liver failure is etiology. Etiology is the strongest predictor. What etiology it is? Hepatotropic viruses generally produces a good prognosis. When you have a hepatitis A or E virus, except for the pregnant woman and hepatitis E combination, apart from that, hepatitis virus and ALF, generally they could do well. They don't, even they go for ALF, so they generally do well. They don't have a bad prognosis. Similarly, paracetamol poisoning, they do generally do very well because we do have a definitive treatment for paracetamol poisoning, like N-acetylcysteine, and we can do a transplantation also, not a problem. But other etiology, like if we have a cryptogenic etiology, don't know the etiology, or non-heterotropic viruses like CMV, EBV, and probably a patient who's getting a fulminant Wilson or a fulminant autoimmune hepatitis, or a patient who's getting idiosyncratic drug reaction. These are things that are generally bad. So etiology-wise, that's going to be the strongest predictor of prognosis. Apart from that, age, presence of cerebral edema, then whether it's the timing, duration, whether it's an acute form or a subacute form, presence or absence of renal failure. Renal failure indicates a poor prognosis. The more the total bilirubin, worse the prognosis is. And patients who are having a multi-organ failure again has a poor prognosis. So depending on the cause, that's the strongest predictor. Apart from that, there are many other things like age, cerebral edema, renal failure, duration of liver failure. I mean, how fast the liver failure happens. At the same time, presence or absence of multi-organ failure. All these things are going to predict the prognosis. But the strongest predictor is always the etiology. You have quite a few questions on acute liver failure, but I think you would have learned so many MCQ points also in this discussion what we have made for the last 40 minutes or so. But nevertheless, next thing what we need to know is the acetaminophen toxicity. That's really, really important. So many points are there to note about the acetaminophen toxicity. So first of all, we need to know the posology. Posology means the study of drug dosages is what we refer to as posology. As far as posology is concerned, acetaminophen is something which we know very clearly at what doses you will have a problem. So, but we know the therapeutic dose. So the usual therapeutic doses of acetaminophen are approximately 500 to 1000 milligram. That's what we use. But in general, there are doses ranging from 325 milligram in certain mixed combinations to up to 1000 milligram you can use per dose, not a problem. That's the rationale of giving that 1 gram paracetamol infusions and all. This is the usual dose, or you can alternatively use 10 to 15 milligram per kilogram per dose. If you are planning to use in a child, you can go for 10 to 15 milligram per kilogram per dose. And you can use this up to every 4 to 6 hours. You can use the same dose every 4 to 6 hours. And the maximum safe dose in clinical therapeutics is approximately 4 grams per day. This is going to the maximum safe dose, or alternatively in children, it goes up to 80 milligram per kilogram per day. So either 4 gram per day, that's the ceiling dose in adults, that's the maximum that we use really, or 80 milligram per kilogram per day in certain areas. In children, especially this will be useful for children. But nevertheless, in my practice, I've used up to 5 grams in certain scenarios, especially the patient is having a high-grade fever continuously, and 3 grams, 3.5 grams, 4 grams is not enough. Maybe I can give one additional shot without any complication, not a problem. But usual recommended safe dose, the ceiling dose of paracetamol is 4 grams per day or 80 milligram per kilogram per day. But when you go for toxic doses depends. For example, I mean, there are 2 types of toxic doses. Either I can take a single toxic dose like 15-20 tablets of paracetamol, or I can take cumulatively. Like I feel bad, like I had a relationship failure or a love failure, and every time I remember my ex-girlfriend, I take one tablet of paracetamol or 5 tablets of paracetamol. This is called a staggered intake or a cumulative intake. So first I have a fear of dying, so I take 5 tablets. Then again, I don't want to take further tablets, but after 3 hours or 4 hours, I feel like little depressed again. I see my girlfriend's photo again, and again I get angry and I take another 5 tablets. So when you take this kind of staggered intake or a cumulative intake of paracetamol, so there are two things that you need to balance. One thing, there is ongoing metabolism of that paracetamol. At the same time, this extra tablets that I'm taking also will keep accumulating. So you have to balance between the elimination as well as the intake. So the dose might be a little higher because it's already getting eliminated. So if you take a single dose paracetamol, single toxic dose, this is what is important for exam, because many of the times you'll be encountering a single toxic dose. If it's going to be a single toxic dose of paracetamol, usually in adults it is 7.5 to 10 grams. 7.5 to 10 grams. So this is a single toxic dose. If it's more than that, it's going to be bad. Or alternatively, if you are talking about children, you can talk about 150 milligram per kilogram per dose. So if it is more than that, so there is a high risk of toxic. This is what is the definition of a toxic dose. Apart from that, anything more than 350 milligram per kilogram per dose, irrespective of the single dose or cumulative dose, doesn't matter. Whether you have taken anything more than 350 milligram per kilogram per dose or probably 350 milligram per kilogram per day. So it could be per dose or could be per day. It is equal to 100% toxicity, definite toxicity. There's no escape from this. Irrespective of the ethnic groups, irrespective of the strength of the liver, irrespective of the hepatoprotectants you're taking, irrespective of the scenario where you're taking, if it is more than 350 milligram per kilogram per day, that's the number beyond which there will be 100% toxicity, definite toxicity. So I think 350 milligram per kilogram per dose or day means it will be coming around, if it's for average 70 kilogram man, I think it will come around maybe to 25 grams. So maybe you can take a tablet like Acton over, or you have this 1 gram tablet, XT para. So these extended combinations are there where 1 gram paracetamol is a tablet is available. So just taking 30 tablets or 25 tablets, I think must kill you, surely. If you don't reach the hospital on time, it should cause severe hepatotoxicity for sure. You might recover, I mean, sometimes because it's all depend on a lot of other factors as well, but there is a definite chance of toxicity if you're going to take more than 350 milligram per kilogram per dose or maybe 50 milligram per kilogram per day, doesn't matter. Suppose if it's a cumulative dose, if it exceeds more than 12 grams per day, then there is a risk of toxicity. So single dose more than 7.5 to 10 gram, cumulative dose more than 12 grams per day. I mean, talking about per day. If it exceeds, there is a risk of toxicity. Similarly, definite risk if the patient is taking more than 350 milligram per kilogram per dose or more than 350 milligram per kilogram per day. So the pharmacokinetics of paracetamol is something which has been very extensively studied again, extensively researched again. So as far as paracetamol is concerned, or I can write acetaminophen, which is correct. As well as acetaminophen is concerned, there are the major pathways where the acetaminophen is getting metabolized. One is the glucuronidation, and second is the sulfation. So it forms glucuronides and sulfates. And these are the things that are basically excreted in the urine. So glucuronides will be excreted in the urine, and sulfates are the ones that are excreted in the urine. So typically around 90% is actually metabolized through this route only, which is a very important route of metabolism. But nevertheless, this route is actually something that can be saturable, which can be saturated. It's a saturable route. It's not something that you can keep on eliminating through this route. If you take more and more number of paracetamol tablet, doesn't matter. At one point, it will get saturated. So glucuronidation and sulfation, 90% of paracetamol is basically eliminated in this route only. And there is a small 5% elimination through the renal route. So directly paracetamol can be excreted in the through the kidneys. That's unchanged in the urine. Without glucuronidation or sulfation, it can be excreted. That contributes around 5%. And 5% is metabolized by the cytochrome enzymes. In reality, I can write CYP450 group of enzymes. And the most important CYP450 enzyme is basically 2E1, even though a lot of other cytochrome enzymes also metabolize, like 1A2, 3A4. All these things also metabolize, but the most important as far as paracetamol is concerned is the CYP2E1. That's a very important one. So this is the one that's going to metabolize this acetaminophen into something called as a NAPK, which is a very toxic compound basically. So 5% is metabolized through to NAPK. So this NAPK basically is converted into a non-toxic NAPK by adding glutathione. So you have a glutathione, good glutathione stores. So this can be converted to, this is a toxic form, all right. But this will be converted to a non-toxic form of a NAPK or a conjugated form of a NAPK. To produce this non-toxic form of NAPK or a conjugated NAPK, your glutathione is very important here. That's why the glutathione stores in the liver plays a very vital role. And remember, paracetamol is very scary, isn't it? Even with routine doses, there is some amount of NAPK that you're actually producing. It's not like you don't produce a NAPK at all. You do produce some amount of NAPK. That's why, when you take the drugs or anything that you take from outside, you should always be scared, because I feel it really scared. I know how you feel it, even though it's converted into a non-toxic NAPK, but it still forms a NAPK, isn't it? Even in a normal liver, 5%. It's not a small number, but it's converted to non-toxic NAPK by glutathione stores, and this will be excreted in the urine. Because it's conjugated, it will be water soluble and will be excreted in the urine. So we don't really feel any problem because of taking paracetamol. But the problem with our excessive dose of paracetamol, let us put in green now. So if you take too much of paracetamol, first of all, this will be saturated. Your sulfation will be saturated. So, it has a limit. So then again, the renal excretion is also only limited. It will be saturated over a period of time. The only thing that is left is your cytochrome-based mechanism. So you're going to produce an excessive NAPK. This excessive NAPK, as long as the glutathione is there, it's not a problem. So you can produce a non-toxic NAPK and you can excrete in the urine. But the problem is glutathione stores are very limited in the body. So once your glutathione stores are depleted, I can write minus glutathione. If you don't have a sufficient glutathione store, or if the glutathione stores are depleted over a period of time because you've taken too much dose of paracetamol, then this toxic NAPK is the one that is going to result in development of liver failure. Ankit is asking, do we need to reduce the dose in Gilbert syndrome? 100% no need. Because Gilbert syndrome is truly and purely a problem due to your this thing, UDP1A1. So UDP1A1 has nothing to do with our paracetamol here, and there is no need to reduce. Only clinically relevant drug that you need to reduce in Gilbert syndrome patients is irinotecan, which I've told you in the last lecture itself. But apart from that, paracetamol, I don't think you need to reduce the dose. You can take the same amount of dose. There is no problem. It's only a myth that in Gilbert syndrome you need to reduce. But apart from that, there's no need to. So this is the one that's going to cause liver injury, and this is the one that's going to cause acute liver failure in the first place. So the problem is this absence of glutathione only. That is why we try to replenish this glutathione. We can replenish this glutathione by giving N-acetylcysteine. N-acetylcysteine basically replenishes glutathione stores in the liver, so that you don't really get this liver injury because of accumulation of this toxic NAPK. Rather than you can convert this into a non-toxic NAPK. But nevertheless, remember, N-acetylcysteine, even though it's considered as many books will give you antidote for paracetamol poisoning N-acetylcysteine. I don't think it's an antidote. Really, it doesn't work on hand to hand. Like, it exactly antagonizes the paracetamol action. It doesn't antagonize. Rather, N-acetylcysteine is something that protects the NAPK form. Protects the liver from NAPK's effect. So by converting NAPK into a conjugate form, that non-toxic NAPK form. So it's not a direct antidote sort of a stuff. But anyway, nevertheless, for colloquial reasons, you can call N-acetylcysteine as an antidote for paracetamol poisoning. But it just prevents the accumulation of toxic NAPK. That's why N-acetylcysteine is going to work, because it replenishes the glutathione stores. And typically the liver injury. So when you talk about a liver injury, when you do a biopsy, where will you see the problem in paracetamol poisoning? What is the typical biopsy finding? Whenever you talk about a paracetamol poisoning, what is the biopsy finding that you're going to see? Anyone? It's very simple, isn't it? It's an easy one. It's not a difficult one at all. This is something you are studying from the second year. Yes, necrosis, but where? Yes. Central lobular necrosis, correct? Basically central lobular necrosis. So that's what you're going to see. So why you see a central lobular necrosis, if somebody asks you, that is because the NAPK formation is actually going to happen maximally in the central lobular area, because in the central lobular area, the highest concentration of cytochrome P450 enzymes will be seen. In the central lobular area, this is the area where you have the maximum concentration of cytochrome P450 enzyme. So that is the reason why typically the NAPK accumulation is more and formation is more in the central lobular zone. That is the reason why you're going to see central lobular necrosis in the setting of paracetamol poisoning. But nevertheless, many students do ask, what do you mean by this central lobular? What do you mean by a hepatic lobule? What do you mean by a portal lobule? What do you mean by a portal triad? What do you mean by all these things? This is something which is a very, very common question asked by many students. But nevertheless, you know what is a hepatic lobule? What is a classic hepatic lobule? Everyone knows that. Usually, typically, the liver architecture will be something like this. They will be arranged in low power itself. You can see this. Even though you don't see lines like this and all, but it's understandable. So this is how you see really. They'll be arranged in this kind of hexagon shaped structures. I mean, if you see that itself, you can get a little bit. So where at every side, you'll be having a hepatic artery, and you'll be having a portal vein. You'll be having a portal vein, and you'll be having a bile duct as well. And some small bile duct will be there. And bile duct will be there. So this is seen in all the corners. So this is what we basically called as a hepatic lobule. This is a classic lobule. So if I want to shade this, so the cells that are present here. So this is what we refer to as a classic lobule, or simply called as an hepatic lobule. And on the other hand, if you want to draw here, I can put a portal vein. This is called a central vein, or I mean, this is not, sorry, not portal vein. This is a hepatic vein. That's a central vein in the center. And if you take this structure and if you see what's really happening, and for example, if you want to take this one cut section and see how it will be there. Already I've drawn this, but just for namesake, I'll draw one more time. So if you see, this might not be the correct one. So to understand it better, let me take this one. This particular slice and see. So if I want to zoom it out and see and that particular area, so you're going to see hepatic artery here, and you're going to see portal vein here. And as I told you, this hepatic artery blood and the portal venous blood will both mix together, and they are going to form something called as a sinusoid. So this is the hepatic sinusoid. And this sinusoid ultimately joins the hepatic vein. So hepatic artery blood and the portal venous blood mix in the sinusoids, and sinusoids will take this blood towards the hepatic vein. So this hepatic vein further will join and so many tributaries of hepatic vein will form the major hepatic veins, and that will join the IVC, which is going to go to the right heart. And in between, as I told you in the previous lecture itself, we are going to have cords of hepatocytes. The hepatocytes will be arranged on all the directions like this. So which is very simple to understand as well. So this is how it is. So you will get cords of hepatocytes here, and the blood will flow into the sinusoids, and the hepatocytes will be arranged within the portal lobule. Okay, so this is how the arrangement is going to be. And we all know what is the space that is present between the sinusoids and the hepatic cells, that is hepatocytes. So these are what we refer to as a space of Dis. We have seen that as well. Space of Dis. And the most important constituent here is the stellate cell. And you can have an odd ito cell also, but stellate cell is going to be the most important here. So why? Because stellate cell is the one that basically what is that? It's the one that's going to manage the sinusoids. It's going to regulate the sinusoidal blood flow. And at the same time, it's the one that regulates the hepatocytes function as well to a large extent. So if you want to see how it works, you can see, take a cut section here and you can see. So if you take a sinusoid and if you see, so I'm taking a cut section here, as I told you. Which means I'm going to take a cut section at this point. So I'm cutting that and I'm seeing what's going to happen. If I see here, you'll have a sinusoid like this, and you'll have a stellate cell that will be like this. for example. So this could be the stellate cell, which I'm drawing. And this is the hepatic sinusoid where the blood is flowing into the tube of hepatic sinusoid. Surrounding, you will have the liver cells. That's different. So we are having the hepatocytes here. That's not important. So this stellate cells, one of the important functions is to produce nitric oxide. And this nitric oxide is the one that keeps the sinusoids open. And whenever there is a serious injury to the stellate cell, or whenever there is a damage to the stellate cell due to some problem, the stellate cell cannot produce sufficient amount of nitric oxide. And at the same time, the stellate cell will go for something called as retraction. So once the stellate cell retracts, the sinusoidal size will become smaller. Once the sinusoidal size becomes smaller, the blood cannot flow through the sinusoids easily, and that's what we refer to as something called a sinusoidal hypertension that happens in patients with cirrhosis. So the main problem that produces this sinusoidal hypertension. So what are the problems that produces sinusoidal hypertension? So one main problem is stellate cell retraction. Stellate cell retraction, and the second thing is loss of nitric oxide. The sinusoids as well as the stellate cells and the hepatocytes, all these things will not produce nitric oxide properly, which we'll be seeing in some time why that happens. So because of so many reasons, you will have this blood flow through the sinusoids becomes very rough, and it cannot happen in the first place. So that is the reason why you get this sinusoidal hypertension. That is very characteristic feature of a cirrhosis. In cirrhosis, if they ask you where is the portal hypertension, it is typically in the sinusoidal level. That's what we call it as a sinusoidal hypertension. That happens in cirrhosis. So that's why the role of stellate cell is something that should not be underestimated. It plays a very important role. Stellate cell retraction is one of the important key pathogenic features that happens in cirrhosis patients, causing sinusoidal hypertension. Because of that, you will get a portal hypertension and a lot of other complications due to portal hypertension. And as I told you, whenever the hepatocytes fail, whenever these hepatocytes are going to fail, means your routine function of the hepatocytes will be lost. In that sense, the blood that is entering the sinusoids will directly reach the hepatic veins, even though little is reaching in the presence of sinusoidal hypertension, but it's going to directly reach the hepatic veins even without getting any alterations by the hepatocytes, because they cannot secrete that protein, they cannot take up the toxins. Also, the blood directly will move from portal vein towards the systemic circulation at a microscopic level. That's why these are called as physiological portosystemic shunts, which we have discussed in the previous section. So that is the reason for encephalopathy, coagulopathy, hypoproteinemia, and so many other problems that you see in liver failure patients. Okay, that is the reason why you need to know what are the problems of liver failure and what are the problems due to portal hypertension. Remember, varicose bleed is not due to liver failure. It is due to portal hypertension. So it may be due to underlying liver failure may be there, but there are two separate entities you should not confuse. One is portal hypertension and second is liver failure. Portal hypertension typically happens due to increased portal pressure. That can be due to sinusoidal hypertension or maybe due to pre-sinusoidal or post-sinusoidal. You have different causes which we'll be discussing in some time. But nevertheless, increased portal pressure is the reason for developing varicose bleed, which I'll tell you in a detailed way in some time. You can develop ascites because of that. You can develop hepatorenal syndrome because of that. You can result in development of something called pulmonary complications, which I'll talk about that in some time. A lot of pulmonary complications. One of the pulmonary complications is hepatic hydrothorax is there. Apart from that, we have portopulmonary hypertension, or we have something called as hepatopulmonary syndrome. So many different complications. All these things is due to portal hypertension, that is increased portal pressure. As far as liver failure is concerned, it is due to loss of actually the function of the liver rather than a portal hypertension. Here, the function of the liver cells itself is lost. One of the important functions of the liver is production of proteins. Hypoalbuminemia can be there, but since hypoalbuminemia is one of the very common in any chronic conditions, we take coagulopathy. So synthesis of coagulation factors will be affected. And second is purification of the blood by the liver cells will not happen. So ammonia cannot be filtered so that you will get a encephalopathy. That's why these are the signs of liver cell failure. So jaundice is not a sign of liver cell failure. Jaundice means just, it's not due to portal hypertension, it's due to poor functioning hepatocytes. Poor function of hepatocytes, but generally jaundice will not be coming under liver failure as such. But jaundice is always a clinical sign of decompensation. Whenever the patient is having jaundice, I call the patient is having decompensated liver disease, but it doesn't mean the patient is having a liver failure. So there are only two things that will suggest the patient, suggest that the patient is having liver failure, that is coagulopathy and encephalopathy. So one has to clearly understand the differences between a portal hypertension versus liver failure. Both are not equivalent. So there might be conditions where you can have a liver failure without portal hypertension. There are conditions where you might have portal hypertension without liver failure also. For example, if the patient is having a severe acute liver failure, ALF, the patient might have only liver failure and they will not have any signs of portal hypertension at all. But patients with a chronic liver failure will have more of portal hypertension features rather than a liver failure, especially if it's due to sinusoidal hypertension. So we will come back to that later on. So both should not be equated. That's the most important point. Portal hypertension is not equal to liver failure. So because, like whenever you're a final year or maybe even a postgraduate level, it's commonly, misunderstood, or probably it's a common notion to get misunderstood that portal hypertension is equal to liver failure. It's not the case. It's completely different. And similarly, after we talked about the hepatic lobule, we have something called as a portal lobule. So what do you mean by the portal lobule? I can draw in this particular image itself. So it will be easier for me if I put a same diagram, one diagram if we draw. So if somebody asks you what do you mean by the portal lobule, I can write, you have a central vein here, you have a central vein here, you have a central vein, all these are hepatic veins. And if you connect three central veins together, connect these three central veins together, the resulting area what you get is what we refer to as a portal lobule. This area is what we called as a portal lobule. This is not clinically important, but still just to know the definition. As far as the portal lobule is concerned, this is, if you see the hepatic lobule, you have 6 pairs of this portal triad. But typically the portal lobule will be centered around a single portal triad. So if you see there is only one portal triad there, you see I can again mark and show you. If you see there is only one portal triad there. So actually this portal lobule's idea is to center around a single portal triad. So that's why it's called as a portal lobule, because it is actually centered around the portal triad, a single portal triad. That's why it's called a portal lobule in the first place. Then we have another thing also, like for example, you have these 3 zones, the histological zones. These are called as Rappaport zones. So we need to know about that as well. So what do you mean by Rappaport zones? Rappaport zones. So we have zone 1, zone 2, zone 3, different Rappaport zones are there. So typically what we do is we take this 2 portal veins, central veins again. So we have 2 central veins and form a quadrangular area. Instead of forming a triangular area, you form a quadrangular area like this. You form a quadrangular area like this. So once you form a quadrangular area like this, you can divide this into 3 zones, in fact. So the first zone, that is this area. So we can put as zone number 1, zone 1. And we have a second area here on either side. This we can call it as zone 2. And the remaining area, maybe I can draw here, that is nearing the central vein. This is what we refer to as a zone 3. So basically, which will be called as a centrilobular zone, zone 1, zone 2, or zone 3, which is near the center of the lobule. Which zone is basically near the center of the lobule? Zone 1, zone 2, or zone 3? Yes, typically everyone knows that is zone 3, that is near the center of the lobule. So that is why zone 3 is what we call it as a centrilobular area. So we have 3 zones, right, isn't it? If you draw like this. So let us talk about the zone 1. Not very important for exams, but there are some trivial questions that you might get. So as far as zone 1 is concerned, this is typically the periportal zone. So why it is called as periportal zone? Because you can see there will be 2 portal triads here. If I mark again, you can see 2 portal triads here. Because I see two portal triads there, and near that portal triad, I'm getting zone 1. That's called as a periportal zone. Typically, this is the zone that will be affected in viral hepatitis very commonly. That is near that area only you will see that Councilman bodies and changes due to viral hepatitis most of the time. At the same time, a lot of toxins can produce damage in this zone. Like for example, phosphorus, very commonly seen in rat killer poisons, and iron overload. Severe iron toxicity, especially acute iron toxicity in patients who are taking cocaine or patients who are eclamptic and HELLP syndrome related changes. Usually you will get in periportal zone only. And we have something called a zone 2, that is otherwise called as an intermediate zone. Intermediate zone, not very important in reality. And clinically, again, this is one of the very unimportant zones. So typically affected in yellow fever. Remember, yellow fever is not even endemic in India. It's only endemic in Africa. We don't have yellow fever. Yellow fever produces similar illness to that of dengue. Dengue is there in India, but yellow fever is there in Africa. And remember like that. So in yellow fever is not endemic in India. And second one is the beryllium exposure. Beryllium poisoning. I mean, again, this is completely unimportant for exams. And the zone 3, which is the most important. That's what we call it as a centrilobular zone. Otherwise referred to as a perivenous zone, because this zone is actually around the central veins. So, I mean, the hepatic vein. So that is why it's called a centrilobular zone. Centrilobular zone is the one that is first affected in certain situations like ischemic hepatitis. You can get centrilobular zone necrosis. And at the same time, you can get an alcoholic hepatitis. Alcoholic hepatitis, centrilobular zone is the one that is very commonly affected. At the same time, it is sensitive to many metabolic toxins like paracetamol. I mean, metabolic poisoning in the sense like CCl4. That is carbon tetrachloride. Then chloroform. We don't use chloroform anyways nowadays. So chloroform toxicity can cause centrilobular necrosis. And at the same time, you can get in one more condition. What is that? Halothane hepatitis. So metabolic toxin. These are things that can result in centrilobular involvement. And of course, paracetamol poisoning. The reason why in paracetamol poisoning is because you have so much of cytochrome P450 enzymes, and the highest concentration of cytochrome P450 enzymes will be seen in the centrilobular zone only, and that is the reason why paracetamol poisoning typically causes centrilobular necrosis. So the most important here is paracetamol causing centrilobular necrosis, but other things, if you want, you can remember. We have 3 zones of Rappaport: zone 1, zone 2, zone 3. Zone 1 periportal, zone 2 intermediate, and zone 3 is centrilobular. Paracetamol typically causes centrilobular necrosis. So I think now the histology of the liver will be clear now, what you mean by the classic lobule, what you mean by a portal lobule, and what you mean by Rappaport zones. And in the Rappaport zones, you now know how to categorize them. What do you mean by Rappaport zone, and what is zone 1, zone 2, zone 3, and all these things will be easy from now on. Okay, they are going to cause centrilobular necrosis only. So what are the clinical features of paracetamol poisoning? As far as the clinical features of paracetamol poisoning is concerned, you have 4 stages: stage 1, stage 2, stage 3, and stage 4. 4 stages are there as far as paracetamol poisoning is concerned. First stage happens in first 24 hours. Second stage happens in 1 to 3 days. And after some, I mean, day 4 is the 4th day. I can write in hours itself, that will be easier. So 24 to 72 hours up to third day is second stage, and after 72 hours, that is up to day 4, it is third stage, and after 96 hours, it is stage 4. Up to 2 weeks, it can be there. 2 weeks. But even though it is quite variable, the different clinical presentations, but these are classic 4 stages of paracetamol poisoning clinically. Usually in stage 1, you will have very non-specific complaints. Still, the patient will be symptomatic. Somebody asks you whether they will be symptomatic or not. They will be usually symptomatic, but they can be asymptomatic. Being asymptomatic does not mean the patient does not have toxicity. The patient usually will be, some symptoms will be there. The most common symptoms will be nausea and vomiting, non-specific symptoms. Right hypochondrial pain, some non-specific symptoms may be there, but they can be asymptomatic as well. Plus, they will have a normal LFT, completely normal LFT. That is the reason why LFTs are not at all useful in the early stage of poisoning. A normal LFT does not rule out a significant toxicity. So as the NAPK keeps accumulating, the liver failure, liver involvement, liver injury starts. So this is the time where the LFTs will become abnormal. LFTs start becoming abnormal, but the patient becomes completely asymptomatic during this stage. So clinical improvement, once again, if the patient is initially symptomatic, after that, if they clinically improve, if the patient tells I'm completely all right, does not mean again the patient is not having significant toxicity. So the LFTs will start getting abnormal in this scenario. And after this, in stage number 3, that is in the day 4. Day 4 is the usual time where the patient dies. Most of this patient die during day 4 only, if left untreated. So where the patient once again becomes symptomatic, where the symptoms of stage 1 will start appearing again. plus LFT abnormalities will be maximal, which means I can take peak abnormalities. Maximal abnormality will be seen around this stage 3 only, that is in the 4th day. So usually during this stage only your enzymes AST, ALT will become thousands or sometimes even 10,000 if the problem is very severe. Often it reaches like 10,000, 20,000 AST, ALT and all. And patients will go for acute liver failure, where usually they die of either coagulopathy due to severe bleeding, or they can go for severe encephalopathy, raised ICP, and they will die. Typically, they don't get that much of jaundice. They might get jaundice. Jaundice is not a sign of ALF. You have to know that. So they might have jaundice. But typically, predominantly, what type of jaundice they ask you, they will get indirect hyperbilirubinemia. Rather than conjugated, they will get an indirect, predominantly unconjugated hyperbilirubinemia. Remember, in a pure ALF, you'll have most of the times you'll have unconjugated bilirubin only. So why again in severe liver failure you'll get unconjugated? Because the liver is not able to conjugate the bilirubin at all. So in a moderate liver failure probably, or a patient who's having a chronic liver failure, it will be a mixed type of a jaundice where they will have some conjugation will happen, but some may be unconjugated. So you'll have that 20 to 50% of direct bilirubin. But in a severe liver failure cases, you might have a predominantly unconjugated bilirubin. That is because the liver is not able to conjugate any amount of bilirubin. So liver cells are destroyed, necrosed. So that's what it means. So predominantly in acute liver failure, you will have more of an indirect hyperbilirubinemia. That's unconjugated hyperbilirubinemia rather than conjugated hyperbilirubinemia. And this is the time where the patient may get hypoglycemia, as I told you. Patient may get acidosis. Acidosis may be due to 2 reasons. Usually it will be an AGMA. The reason for developing this AGMA is due to 2 reasons. One is the oxoproline metabolite that accumulates in paracetamol poisoning, and second is the lactate elevation. So one is lactic acidosis, and second is that oxoproline accumulation. So both can cause AGMA. AGMA is the usual entity, and they can get acute kidney injury, which can happen in almost 2 to 5% of the individuals, especially with patients with paracetamol injury. Usual reason for developing this AK is acute tubular necrosis. That is due to direct effect of paracetamol on the kidney itself. The most common cause of death is stage 3 only. So this is the time where the patient usually dies in a paracetamol poisoning. And then patients who survive this stage will enter the stage 4 either due to treatment or without any treatment. Sometimes they can survive even without treatment. The liver might recover from the injury. So patients who survive beyond 96 hours or patients who don't develop any complications beyond 96 hours, they usually recover. So this is a stage of recovery. And most important point to notice, recovery, once it happens, it's complete. Remember, only patients who survive the stage 3, the assault is, once the patient survives the assault that happens in stage 3, they will go for recovery. And once the recovery happens, it's complete. I mean, many patients can survive even without treatment. That's different because the liver, we have a tendency to fight. So the liver can regenerate and liver can recover from that particular injury, even without treatment also, doesn't matter. So it does not mean without treatment they will surely die. They might survive without treatment also. I've seen a lot of patients like that who's coming after 6 days, 7 days. Enzyme abnormalities will be there at the time of presentation, but automatically will resolve even without treatment. So a liver might recover, but once it recovers, it's complete. Remember, the most important thing to notice, paracetamol poisoning is not a cause of cirrhosis or a chronic liver disease. It's not going to cause any chronic long-standing sequelae. Very, very, very important point. It's never going to cause any sequelae. Paracetamol poisoning is not a reason for cirrhosis or a chronic liver disease. Once recovers, it's 100% recovery. It's a complete recovery. They're not going to cause any sequelae, for sure. Now going to the treatment. As far as treatment is concerned, initially you follow the toxicology protocols, as simple as that. So first I'm going to use an activated charcoal. Activated charcoal, typical dose, we know it is 1 gram per kilogram to a maximum dose of 50 grams is what you can give. Typically, this is the same toxicology profile that I've taught you multiple times in the past in many special classes. So 1 gram per kilogram, 50 grams, you have to give within 4 hours of ingestion. Within 4 hours of ingestion. Remember, usually 1 hour for many other poisons. But in paracetamol, you can extend up to 4 hours because paracetamol causes some form of gastroparesis, where the paracetamol tends to get retained within the stomach for a longer time. That's why here alone you can give up to 4 hours. But in many of the poisons, you have to give within 1 hour. Otherwise, it won't be effective. And second is specific treatment, that is N-acetylcysteine after activated charcoal. As far as N-acetylcysteine is concerned, you can give oral treatment or IV treatment. Remember, oral treatment is given for patients who don't have GI symptoms like nausea, vomiting. IV treatment for patients who have nausea and vomiting. As far as oral treatment is concerned, you can start with the loading dose initially. The typical loading dose is 140 milligram per kilogram of N-acetylcysteine. That's the loading dose. Then this will be followed by maintenance dose. Maintenance dose is typically 70 milligram per kilogram, half the dose. And this will be given every 4th hourly for a minimum of 17 doses. You can extend, not a problem, but minimum you have to give 17 doses. After that, you can extend. Depending on the clinical profile, you can extend the doses to 30, 40 also, but 17 doses is minimum. So 140 milligram per kilogram loading, then followed by 70 milligram per kilogram of maintenance dose. Then as far as the IV protocol is concerned, typically again you need to give a loading dose. Loading dose is typically 150 milligram per kilogram. Usually we give as a 1 hour infusion, especially if patients are having severe nausea, severe gastrointestinal symptoms like nausea, vomiting, or they're not able to take N-acetylcysteine. If they get that nausea, vomiting, then you can give IV loading dose of 150 milligram per kilogram, then followed by a maintenance dose. Maintenance dose, usually we shift into 2 protocols. This is called as accelerated protocol. That's what we follow. Accelerated protocol in the sense we are going to give 50 milligram per kilogram for 4 hours, 50 milligram per kilogram over 4 hours. So, or you can write as maybe 12.5 milligram per kilogram per hour for 4 hours. Then this will be followed by 100 milligram per kilogram dose. 100 milligram per kilogram per hour, 100 milligram per kilogram per kilogram dose, which will be giving over 16 hours. Typically, we'll be giving 6.25 milligram per kilogram, I think, per hour for 16 hours, half the dose of previous dose. So usually what I remember is giving 150 milligram per kilogram, then followed by 12.5 milligram per kilogram per hour for 4 hours, then half the dose of that 6.25 milligram per kilogram per hour for 16 hours. So total, this is called as 20-hour accelerated protocol. This is the one that is currently approved. And many other protocols are also there. There are 7 different protocols for giving N-acetylcysteine, that nevertheless, this is the most commonly used protocol in practice, and this is called an accelerated 20-hour protocol. So this is what we use. And this is actually a very slow protocol where you give oral N-acetylcysteine. This is called the oral 72-hour protocol. This is an IV 20-hour protocol. This is also referred to as accelerated protocol for giving N-acetylcysteine. This is the usual protocol that we follow in many tertiary centers. And the most important things about NAC is anytime. I mean, it's best if you start within 8 hours. You can start around 8 to 16 hours also. It's okay if you start at around 8 to 16 hours also. But benefit is questionable if it is started after 16 hours. After 16 hours, the benefit is highly questionable. Whether it is beneficial or not, we don't know. But nevertheless, you start ASAP, that's all. Start N-acetylcysteine as soon as possible. I mean, it doesn't mean, even though this tells you the efficacy of the N-acetylcysteine at what time, if you start, what will be the efficacy. But nevertheless, in clinical practice, you start at any time, not a problem. Why I'm trying to tell that is because even though 90% of the central lobular area is necrosed or 90% of the liver is necrosed, still you have 10% that is still left, which are still susceptible to NAPK effect. So that you can stop. The 10% at least you can salvage by giving N-acetylcysteine. So doesn't mean you should not give N-acetylcysteine. So even though you have some timings where the N-acetylcysteine's effect will be best, but no problem. At any point, if the patient comes, you can start with N-acetylcysteine. Even if the patient comes with liver function test abnormalities, transaminase of 10,000, 20,000, patient is having a frank acute liver failure, doesn't matter. You are anyway going to start with N-acetylcysteine, irrespective of the timing. But it is best effective if you start within first 8 hours. Remember, in the first 8 hours, the patient may not have any problem at all. Patient may not have symptoms. Patient may not have, may have mild symptoms, but they might be asymptomatic. They may not have LFT abnormalities. Their OTPT may be completely normal. Still, I start with N-acetylcysteine. So that is the best timing to start, because the idea of giving N-acetylcysteine is to actually prevent further damage caused by NAPK. So if the patient has not got any NAPK-related liver injury, it's well and good. You start with N-acetylcysteine to prevent any further effects of NAPK that is happening. So that is why AST, ALT have no role in initiation of treatment. Whether the patient is having normal left, it doesn't matter. Patient is having 10,000 or 20,000 AST and ALT, doesn't matter. Anyway, you're going to start with N-acetylcysteine. So the patient AST and ALT does not play any role with respect to starting the N-acetylcysteine in the first place. N-acetylcysteine can be given in patients who come with acute liver failure and encephalopathy as well. Doesn't matter. And there is one important nomogram that has to be followed. That's called a Rumac-Mathy nomogram. I mean, this will be helpful. I'm not telling this should be followed. This will be helpful. Whether to continue with paracetamol or not. Nevertheless, the first dose of paracetamol is something which has to be, first dose of N-acetylcysteine is something which has to be given. Whether to continue with N-acetylcysteine or not, this Rumac-Mathy nomogram will be extremely helpful. So, what is this nomogram? This nomogram should be applied only for single dose intake, single dose toxicity. It should not be used for patients who have taken multiple doses and within 24 hours. The patient is coming within 24 hours and the patient has taken single dose, then Rumac-Mathy nomogram will be effective. Suppose the patient has taken multiple doses and time elapsed is more than 24 hours, then this nomogram may not be that predictive or helpful. So that small point that you need to know. So what is this Rumac-Mathy nomogram? You will have a graph where there will be a time that will be plotted against the paracetamol levels in the blood. So you need to take paracetamol levels in the blood. And there will be a line like this, if you see. This is basically called as a treatment line. Please understand, this line typically starts at 4 hours only. So which means the time where you have to take the paracetamol levels for the first time, the first paracetamol level in the blood should be taken at 4 hours only. Suppose if you want to see the serum acetaminophen levels, the first level monitoring should be done at 4 hours only. Then we'll be doing at every 4 hour interval, but nevertheless, the first thing should be done at 4 hours. The patient is coming after 4 hours, then no problem. You can take any time, not an issue. You can take as soon as possible. But if the patient is coming within 2 hours of paracetamol intake, then there is no point in doing serum paracetamol levels. You better load with N-acetylcysteine in that scenario, but don't wait for the paracetamol levels. But you wait for another 2 hours to take paracetamol in this situation. Clear? So first paracetamol level in the blood should be sampled at around 4 hours. So that is the take-home point by this Rumac-Mathy nomogram. So why there is a line like this? Because depending on when the patient is coming, depending on when the patient is reaching you, there is a different levels of paracetamol beyond which you need to start the treatment. Suppose the patient is coming to me at 6 hours. In this situation, don't think that I should not start with N-acetylcysteine. I will still start with the loading dose of N-acetylcysteine, but I'll wait for the paracetamol levels to come. So at 6 hours, I'm seeing the nomogram, and if I see my paracetamol levels are beyond this, then I can start the treatment. If the paracetamol levels are below this, I can actually withhold the treatment. There is no need to treat. I can wait for some more time. I can wait for the next level. So only the loading dose I'll give, the next dose I'll be waiting. So the nomogram will tell you whether to treat or not, number one. At the same time, when to discontinue the treatment also to some extent. So it can tell you. That's why the nomogram is helpful. But remember, the nomogram will be helpful only if it's a single dose intake and the patient coming to you within 24 hours. But if the patient comes beyond 24 hours or if the patient is having a multiple intake or a staggered intake, then in this situation, I don't really give N-acetylcysteine. I'm not going to use Rumac-Mathy nomogram in the first place. But nevertheless, you need to know about this Rumac-Mathy nomogram for exams at least. They might ask you. Apart from that, other important things about N-acetylcysteine. N-acetylcysteine is safe in pregnancy, safe in children as well. It might cause mild allergic reactions like small urticaria. Sometimes some patients may go for minimal anaphylactic reactions, but that does not mean you should stop N-acetylcysteine. You should continue to give N-acetylcysteine nevertheless, because the protective effect of N-acetylcysteine is actually much higher compared to this small kind of reactions. So in fact, it can be given in pregnancy, even though if I ask you it is safe in pregnancy, means it crosses the placenta or it does not cross the placenta? Cross or does not cross? If I tell you it is safe in pregnancy. it actually does cross the placenta. It is extremely safe in pregnancy. Yes, actually it is actually crossing the placenta, but that crossing the placenta is quite important because that actually protects the fetal liver also. Because sometimes, because of maternal excessive intake of paracetamol, it can cause fetal liver necrosis. Fetal liver is actually more sensitive. The dose is actually quite less for the fetus compared to the mother. So the fetal liver necrosis is a common complication in mothers taking excessive paracetamol. So even the dose is actually much lesser for fetus. So giving analgesics in pregnancy is actually safe, even though it crosses the placenta, because it crossing the placenta is actually producing the fetal liver protection also. So that's why it has to be given in pregnancy in the first place. And second thing, it is not protective against AKE. AKE cannot be protected. If there's a kidney failure, that N-acetylcysteine has no effect on the kidneys. In the sense, like if the patient is having AKE, that's an independent event. So N-acetylcysteine will not give any protection for the kidneys in the first place. And the most common side effect of N-acetylcysteine, I told you already, it is gastrointestinal symptoms. Almost 1/3 of the patient will develop some kind of vomiting, gastritis kind of a thing. But it's fine. You still have to continue with N-acetylcysteine. If it's severe, then you can go for IV. That's enough. That's okay. But you have to continue with N-acetylcysteine. And second most common side effect is the hypersensitivity reaction. Some rashes or urticarial reactions can happen, but still you have to continue. You need not stop the N-acetylcysteine because of that. Suppose if the patient vomits within 1 hour of taking N-acetylcysteine, then repeat the dose. After 1 hour, if they vomit, no problem. But if the vomiting happens within 1 hour of taking the previous oral N-acetylcysteine, you have to repeat that dose because there is a lot of chance that N-acetylcysteine should have come in the vomitus. But within 1 hour. Beyond 1 hour, then no need to repeat. What are the indications to stop? When will you stop N-acetylcysteine? So number one, the Rumac methanomogram will be very helpful if you have especially undetectable acetaminophen levels. It goes below the certain limit where you cannot detect the acetaminophen levels at all in the first place. Or if ALT becomes normal, or if it decreases by more than 50% from the initial value. So either the ALT remains normal or becomes normal, or if the initial ALT is elevated and if it is decreasing by more than 50%. And third, if the patient is coming with an acute liver failure, once the INR becomes less than 2, so these are the indications. Whichever is applicable according to the clinical scenario, you can follow that particular indication to stop an N-acetylcysteine. Clear? So these are indications to stop N-acetylcysteine in the first place. So this is a detailed review on paracetamol poisoning. Paracetamol poisoning is very important for your exams. But if the question is very trivial, they will be asking you only about N-acetylcysteine. But there are so many things to know in paracetamol poisoning. And remember, the most strongest predictor of toxicity is the dose. That's all. So if they ask you what is the strongest predictor of toxicity, or what is the most important clinical predictor of toxicity, that is the dose, as I told you already. Apart from that, delay in treatment also is one of the predictors, but more than that, the dose is the most important. And patients who are taking alcohol, remember, alcohol has a double effect on paracetamol toxicity. Many students think that alcohol can result in more paracetamol poisoning, but no. It depends on whether it is an acute alcohol intake or a chronic alcohol intake. So if it's an acute alcohol intake, acute alcoholic binge, because many patients do take some toxin along with the alcohol. That's a very common practice. It's an acute alcohol binge. It's not a known chronic alcoholic, but acutely is taking too much of alcohol along with paracetamol. Basically speaking, the damage will be less damage in these patients. Why? Because alcohol will use the CYP450, 2,450 enzymes. Alcohol will use the CYP450 enzymes for its own metabolism, leaving very little for paracetamol to produce NAPK. So that's why acute alcoholic binge, you might not get that much of toxicity as you expect. But in chronic alcoholics who's taking excessive paracetamol, you might have actually more toxicity compared to acute alcohol binge. So why chronic alcoholics with paracetamol poisoning can get more toxicity? That is because chronic alcoholism will induce, because alcohol needs that CYP450 enzymes. Chronically, if you take alcohol, there will be induction of the CYP450 enzymes. So because the CYP450 is induced in this situation, these patients taking paracetamol may produce more NAPK than what usual patients produce. So that's why they have more toxicity. So acute alcoholic binge is associated with lesser toxicity than you expect, but a chronic alcoholism may be associated with more toxicity than you expect. But again, this is not something that is applicable in clinical practice all the time. Similarly, patients who are having cirrhosis actually have a lesser effect. Why? Because of two reasons. Already cirrhotic patients means their effect on the liver will be very poor, because already liver is destroyed. What's the fun in destroying more? So then nothing much that's going to happen. And second thing, cirrhosis patients will have very little CYP2450 enzyme. I mean P450 enzymes, because they have lesser CYP450 enzymes. Their NAPK formation is also quite less. So cirrhotic patients, as you expect, again they behave a little variably. You cannot predict that they will have more toxicity or they'll have lesser toxicity. Again, asking, can we give alcohol for people that are very far from the hospital? I don't know. It is only a understanding, but it doesn't mean that we can use alcohol as an antidote in this situation. Not possible in the first place. And smoking has a higher risk, because smoking induces CYP450 enzymes. So especially 2E1 is induced with smoking. Smoking has a higher risk. Age more than 40 has an extremely high risk, because again, any liver disease, if age more than 40 means you'll have always a high risk. So that's very important. So the most important predictor is your dose. That's the most important predictor. And second is delay in treatment. Third is alcohol has variable effects. Fourth is malnutrition, reduced glutathione stores, more effect. Smoking, induction of CYP2E1 can have more effect, and age more than 40, little bit of poor prognosis. 6 factors that I told you. So dose, most important. Delay in treatment, alcohol, variable effects. Then malnutrition, reduced glutathione stores, more problems. Smoking, 2E1 induction, so more NAPK, more problems. Age more than 40, maybe having lesser glutathione, so more problems. So this is the idea. So then another cause of acute liver failure is something called as Ray's syndrome. Ray's syndrome, everyone knows in exam. Previously, it was called as something called as a Jamshedpur fever. That's how it was defined previously. But nevertheless, it is quite common in children. Previously, not now, because currently we know the reason for developing Ray's syndrome. The incidence of Ray's syndrome right now has completely dropped down, and I have never seen even a single case. But it's only historical thing. It's only theoretical and textbook-based scenario. But we have never ever seen till now Ray's syndrome. I mean, because we don't use aspirin at all in children. So children less than 19 years, typically you will be around 5-6 years of age. Most commonly around 5 to 10 years of age. But children who's typically less than 19 years of age, plus recent viral illness, it is believed that most probably it is influenza. And again, with routinely giving influenza vaccine, that is also one reason why this has completely gone down. So recent viral illness, it could be varicella infection also, like chicken pox. It could be influenza, but influenza is quite common. Recent viral illness, usually this will happen recent in the sense like 3 to 5 days prior to the incidence of the disease. I mean onset of the illness. Apart from that, they will be developing acute liver failure. So children, along with that, they will have history of, most importantly, salicylate exposure. Salicylate use, especially aspirin. Plus, they will develop acute liver failure, presenting with acute liver failure. So this is typically a Ray's syndrome. So children's recent viral illness, history of salicylate use like aspirin, presenting with acute liver failure, is Ray's syndrome. So what are the features of ALF? The most important feature in Ray's syndrome is encephalopathy, that is due to hyperammonemia. That is the one that is mostly affected. That is the classical feature of Ray's syndrome. They come with hyperammonemia only. Plus or minus, they can have jaundice, coagulopathy, and other problems also. Coagulopathy, acidosis, hypoglycemia. These are other problems which can be there. But the most important characteristic feature of Ray's syndrome is encephalopathy. That's why they come. That is due to hyperammonemia. So this is a classic presentation of Ray's syndrome. Mostly it is clinically diagnosed, but if you do a biopsy, typically you will see a steatosis. Again, this is one of the conditions which produces severe fatty infiltration of the liver acutely, that causes liver failure. And there are many postulates why this steatosis happens. We believe that salicylate metabolites of salicylate accumulate, that produces hepatic mitochondrial injury. The salicylate use produces mitochondrial injury. Mitochondrial injury produces two problems. One is reduced ATP production, which is dangerous to the liver cells. At the same time, they will inhibit the fatty acid oxidation. And it is believed that viral illness can also inhibit fatty acid oxidation. So because there is severe inhibition of fatty acid oxidation, at the same time there is reduced production of ATP, your fatty acids cannot be metabolized in the liver, will go for steatosis, and that steatosis inducing a damage to the liver, causing acute liver failure. This is the theory that is postulated, but nevertheless that is not important in the first place. So biopsy will show severe fatty infiltration of the liver, and typically this steatosis will be a microvesicular steatosis. This is something that's a very old question asked in the first decade of the 21st century, like up to 2010 they used to ask this question, microvesicular steatosis in Reyes syndrome. But apart from that, this is not important. Treatment is only conservative, supportive management. Most of the time the children will recover, no problem. So currently we don't get, because we never use, pediatricians never use aspirin for any fever in children. We use only paracetamol, number one. And one more important exclusion that you need to know is aspirin use in Kawasaki disease has been questioned extensively, because most of these children Kawasaki disease will be less than 1 year, typically around 5 years, but most commonly happens in age less than 1 year. That's the classic feature of Kawasaki. So aspirin used in Kawasaki is not associated with increased risk of Reyes syndrome. So that has been investigated extensively, because aspirin is one drug that is not used in children, especially those who come with fever. But aspirin used in patients with Kawasaki has been questioned for a long time, because it's been proposed as one of the important reasons for developing Reyes syndrome. But aspirin use in Kawasaki has been drilled in and out by trials, but none of these trials showed increased risk of Reyes syndrome if you use it for Kawasaki disease. So you can use aspirin safely for Kawasaki disease, not a problem at all. That's the idea. Similarly, there is one drug that can present with Reyes syndrome like picture, especially in children, that is valproate. Valproate is something that causes severe steatosis again. It produces fatty liver. Because of severe steatosis, they can present with an exact Reyes syndrome like presentation. But if you have a valproate use, and if you get a Reyes syndrome like picture, you don't call it as a Reyes syndrome, it's a valproate heterotoxicity. That's different. Valproate itself can cause steatosis, and that is producing Reyes syndrome like effect. That's all. So that's another thing that you need to know. They can produce exactly the children who use valproate getting toxicity, they come with a Reyes syndrome like presentation. That's a question that's been asked multiple times once again. And next thing that we need to know is chronic liver disease, CLD, and the problems due to chronic liver disease. That's what I'm going to see. Only the pathophysiology we'll be seeing now. So we won't be seeing about the details right now. Tomorrow I don't know whether I can start or not, because tomorrow I have some small, another minor procedure. That's a second stage procedure that I'm going through tomorrow. So based on my pain, post-operative pain, I might not be able to take the class tomorrow. So I'll be informing you when I'll be taking the next session. But tomorrow I don't think I can take. So note that point. Anyways, we'll be discussing again. So we'll be continuing with the CLD, but today I'll be telling about some important points on CLD. So as far as the chronic liver disease is concerned, here are some causes. Most common etiologies of chronic liver disease, cirrhotic and non-cirrhotic, we need to know, because cirrhosis is also a form of chronic liver disease, but where cirrhosis is actually a pathological definition, where there will be destruction of the liver architecture. The liver architecture will be completely gone. You don't see the classic hepatic globules, and architecture will be lost with the formation of nodules, shrunken liver. So this is what we call it as a cirrhosis. As far as cirrhosis is concerned, in India, it's always the alcohol. Alcohol is the number one cause of cirrhosis, then followed by chronic viral hepatitis. Chronic viral hepatitis. In Western world, it's always the chronic, it's a reverse. Chronic viral hepatitis is the usual cause in Western world compared to alcohol. Which tells you one important thing, that Western world, they take alcohol, but they know how much to take. But Indians, you don't know how much to take. So that's why alcohol is the number one cause of cirrhosis in India. But chronic viral hepatitis is also important. But in Western world, chronic hepatitis is viral hepatitis is the most common cause. As far as chronic liver disease is concerned, chronic liver disease does not mean it's a cirrhosis. Any patient who's having a liver disease for more than 6 months is what we refer to as a chronic liver disease, in the form of jaundice or elevated liver enzymes or whatever may be the case, or HbA1c persistence for more than 6 months. We call it as a chronic liver disease. The patient is having a chronic liver disease, then usually the reason will be chronic HBV. That will be the usual cause. Chronic HBV, then followed by chronic HCV. So this is the usual cause of chronic liver disease. As far as Indians are concerned, remember, this is also referred to as a non-cirrhotic liver disease. If you exclude the cirrhosis, non-cirrhotic CLD typically will be due to viral hepatitis only. That is due to chronic hepatitis B virus in India. But in Western world, it's chronic HCV, not chronic HBV. As far as hepatocellular cancer is concerned, once again, your most common cause will be chronic HBV in India, followed by chronic HCV. This is the usual cause of HCC in India. In Western world, it is chronic HCV again. In Western world, again, it is chronic HCV. As far as your liver transplantation, the reason for orthotropic liver transplantation, most common cause in the entire world is chronic HCV only. Chronic HCV is the most common cause of orthotopic liver transplantation in the entire world. So cirrhosis, most common cause alcohol. Chronic liver disease and chronic hepatitis, most common cause is chronic HBV. Hepatocellular cancer, again in India it is chronic HBV, that's common. Whereas most common cause of orthotopic liver transplantation anywhere in the world is chronic hepatitis C virus only. But nevertheless, in Western world, it will become chronic viral hepatitis, chronic HCV here, chronic HCV here, and chronic HCV here. That's why many of the Western textbooks give so much importance on hepatitis C virus, because it's extremely common in that setting. So that is the most common cause of cancer, chronic hepatitis, as well as cirrhosis, as well as your reason for liver transplantation in the Western world. But in India, there will be some changes will be there, where alcohol remains the number one cause of cirrhosis. Alcohol usually does not cause chronic hepatitis. It can cause alcoholic hepatitis, but most often they present with cirrhosis if they take alcohol for a long time. Okay. So cirrhosis, alcohol, non-cirrhotic CLD, chronic hepatitis, especially HPV in India. In developing countries, it's always hepatitis B virus, not hepatitis C virus. And what are the etiology of chronic liver disease? What are the etiologies of chronic liver disease? As far as the etiology is concerned, it can be due to hepatotoxicity, damage to the liver. It can be due to inflammatory damage by the immune system, or it can be due to some metabolic disorders, which can cause chronic liver disease and subsequently cirrhosis. So as far as hepatotoxicity is concerned, alcohol is a very important cause. Then drugs can cause, a lot of drugs, like very important for exams are methotrexate and amiodarone, very important drugs, even though countless number of drugs can cause hepatotoxicity. And aflatoxin can cause CLD, but paracetamol never, right? No paracetamol. Paracetamol never causes a chronic liver disease, 100% for sure. And as far as inflammatory injury is concerned, the topmost cause is chronic viral hepatitis. This is the number one cause. Primary biliary cirrhosis is there. Primary sclerosing cholangitis is there. Autoimmune hepatitis is there. And we have some parasitic infections like schistosomiasis, leishmaniasis, which can cause chronic liver disease. But the number one cause here is chronic viral hepatitis. The number one cause here is alcohol. That's all. But we do see a rare case of AH, PBC and all. I don't disagree with that, but still, number one is always chronic viral and alcohol. In metabolic disorders, NASH is extremely common. When you leave this alcohol and chronic viral, the another reason that is extremely common for producing chronic hepatitis and chronic liver disease, NASH, that is non-alcoholic steatohepatitis, which we'll be discussing subsequently. And you have hemochromatosis due to iron deposition, rare disease, Wilson disease, again rare disease. And we have some specific forms of alpha-1 antitrypsin deficiency, only specific forms, again rare. And problems in hepatic vein congestion, like Buchiari syndrome, cardiac cirrhosis, like for example, constrictive pericarditis or severe right ventricular failure can result in hepatic vein congestion, resulting in congestive hepatomegaly and cardiac cirrhosis in the long run. But three most important causes that we need to know that we commonly and routinely see in India is alcohol, chronic viral hepatitis, and NASH. These are three causes. Most of the times our causes will be circulating around these three only. So chronic viral, NASH, and alcoholic liver disease. And what is the problem and what's going to happen in these patients, and why they suffer from various problems? So first thing, we need to know about the older classification of cirrhosis. As far as cirrhosis is concerned, we can split into a micronodular cirrhosis and a macronodular cirrhosis. Suppose if it's less than 3 millimeter nodules, we call it as a micronodular cirrhosis. And if it's more than 3 millimeter nodules, we call it as a macronodular cirrhosis. Micronodular or macronodular cirrhosis. I mean, the number one cause of micronodular cirrhosis is alcohol, even though it is variable. And number one cause of macronodular cirrhosis is chronic viral hepatitis. Again, chronic viral hepatitis. And many metabolic causes like Wilson disease, alpha-antitrypsin deficiency, all these things will result in micronodular cirrhosis, whereas autoimmune hepatitis will result in a macronodular cirrhosis. And typically, the primary biliary cirrhosis will result in micronodular cirrhosis. There are some conditions like galactosemia and Indian childhood cirrhosis, which happens in childhood. These are all extremely rare entities called as Indian childhood cirrhosis. Currently, this kind of terminologies is completely questionable. It's been replaced with the term called cryptogenic cirrhosis, but just for your exam sake, because one of the old questions they ask is Indian childhood cirrhosis produce micronodulars. That's why I told you that point. But currently, this term is completely outdated now. We don't use the term ICC right anymore. So, but nevertheless, then we have Budd-Chiari syndrome. All these things can produce micronodular cirrhosis. But remember, virtually even any micronodular cirrhosis in late stages can produce a macronodular cirrhosis. Only in early stages there will be micronodular, but in late stages they can become a macronodular cirrhosis. The reason for developing a micronodular cirrhosis is uniform involvement of the hepatic lobules. If all the lobules are uniformly involved, you will have micronodular cirrhosis. If it's involved non-uniformly, then you will result in a macronodular cirrhosis. That's all. So which means in later stages of cirrhosis, due to any cause, there will be non-uniform involvement and there will be complete destruction of the architecture of the liver. So you'll result in macronodular cirrhosis only. So this distinction of micro versus macro, again, is not of any clinical relevance in the first place. If you ask, one of the useless things is to differentiate into micronodular as a macronodular cirrhosis. It's not going to be helpful for your treatment. It's not going to be helpful for your diagnosis. You're not going to diagnose a viral hepatitis based on micro or macronodular cirrhosis. You're not going to diagnose an alcoholic cause based on micro or macronodular cirrhosis. This is absolutely absurd. And I don't know why they ask these questions in the exam, but absolutely of no clinical value. And it's not going to be of any use in the first place. So just for exam's sake, you might be needing to know alcohol, metabolic causes, chronic viral, AH, and maybe PBC. That's all. These are the three things in micro and two things in macro that you need to know, which can cause micronodular versus a macronodular cirrhosis. Yes, fine. These are going to be the etiology. So etiology wise, cirrhosis, think about alcohol, chronic hepatitis and chronic liver disease, think about chronic viral hepatitis in India, and liver transplantation always HCV. And etiology wise, hepatotoxic, inflammatory versus metabolic, micronodular versus macronodular, micronodular alcohol, metabolic PBC, macronodular, chronic viral hepatitis, and autoimmune hepatitis. And literally any cause of micronodular cirrhosis in late stage can result in macronodular cirrhosis. So this is the final take home point. And apart from that, clinical features of CLD, so many things are there, especially you would have studied the features of liver cell failure. The same thing I'm going to tell once again. So I can split into hand and nail. That's why I ask about, I ask an undergrad in exam, hand and nail, face, then chest features, chest wall, and finally abdominal features. What will be the abdominal features? So as far as hand and nail features are concerned, many patients may have leukonychia because of low protein and anemia that these patients will have. And the second thing is palmar erythema. It's one of the important signs of liver cell failure. Especially this happens in patients due to alcohol intake, but non-alcoholic cirrhosis may or may not have palmar erythema. And third is clubbing. One of the important cause of, non-pulmonary cause of clubbing is cirrhosis. Even celiac disease can cause clubbing. Everyone knows that IBD can cause clubbing. So many other disorders, non-pulmonary cause can cause clubbing. One of the important non-pulmonary cause of clubbing is cirrhosis. And Dupuytren's contracture, we know that. Dupuytren's contracture. Remember, Dupuytren's contracture typically affects the little finger and then the ring finger. Usually, this is the area where they will have a contracture in Dupuytren's contracture. It's rare to have this this thenar area involved. Usually hypothenar area and the ring finger, the little finger is the one that's most commonly affected, then followed by ring finger. This is the one that will be curved like this in patients. Very common in alcohol intake related cirrhosis, Dupuytren's contracture. And we have Terry's nails. Everyone knows what you mean by Terry's nails. The proximal 2/3 of the nail plate will be white, but the distal 1/3 will be a little red. That is different from half and half nail. That is called Lindsay nail. That happens typically in renal failure patients. But the only slight difference with Terry's nail and Lindsay nail is what is the pattern of hyperpigmentation. You can go back and see later on. But Terry's nail in exam goes towards a liver problem, and Lindsay nail, that is half and half nail, that goes towards a renal failure most often. but again, not of much clinical value. Then we have some facial features. Other facial features are concerned, you can see this telangiectasias, that is again due to hyperdynamic circulation and capillary proliferation. Then you can have something called a paper dollar skin. In US, it's quite common. It look like a dollar note, especially in white people. That's called a paper dollar skin. Then you have some kind of erythematous tongue erythema. Tongue will look red in nature, and especially in alcohol, is quite common. And patients can have icterus, scleral icterus, that is a yellowish tinge on the sclera because of high bilirubin. They can have xanthelisma. Can you tell where xanthelisma happens? In exam, which liver disease? Xanthelisma becomes very important. You see that you can diagnose that liver disease. What is that in the paper? What is that liver disease you're talking about? When you see this point, you can tell it's that particular liver disease. That's all. I'm not getting any answer. PBC, primary biliary cirrhosis. Remember, any cholestasis can cause. Any chronic cholestasis can produce xanthelisma. But remember, PBC is one of the conditions in exam. Very classically, they'll give the xanthelisma because it's a condition that produces chronic cholestasis. So, see xanthelisma in exam, go for PBC. Most of the times you will be right. And fetor hepaticus. That's again a sign of liver cell failure. Everyone knows that. And what are the chest wall problems? That's why the chest wall problems are concerned. You can get this two important problems. That is gynecomastia. Everyone knows that. That's due to hyperestrogenism. Or females can develop breast atrophy as well. Due to variety of factors, breast atrophy, gynecomastia in males, but breast atrophy in females. Breast atrophy in females. And third thing, they can go for spider angiomas, which is very commonly seen in the chest wall only. That is again due to hyperestrogenism. Spider angiomas. Clear? Dilated arteriole with like a spider leg-like appearance. Spider neve, also called a spider neve, isn't it? Then abdominal complications, abdominal problems. Caput, everyone knows that that's a sign of a portal hypertension. And you might see a splenomegaly, once again a sign of portal hypertension. And ascites, once again a sign of portal hypertension. And you can see loss of secondary sexual hair, especially pubic hair, chest hair and all will be very sparse. And they can have a testicular atrophy, low testicular volume, very characteristic feature of chronic liver failure and cirrhosis. And you can hear that hyperdynamic circulation and that dilated portal circulation due to portal hypertension in the form of a murmur called as Curvillier-Baumgarten syndrome or Curvillier-Baumgarten murmur. I don't know the spelling correctly, but I think it's Baumgarten. But nevertheless, there is a murmur that you see near around the umbilicus. That's due to dilated veins having more flow. That's called a Curvillier-Baumgarten murmur that you can see in the abdomen. So these are the usual signs of chronic liver disease and cirrhosis. But remember, most of the times chronic liver disease patients can have cirrhosis or chronic liver disease patients may not have cirrhosis, whether they have cirrhosis or whether they don't have cirrhosis or whether they have liver failure or they don't have liver failure. Depending on that, I am going to tell what symptoms may be there or may not be there, but these are the general features of a chronic liver disease and a cirrhosis. In that, what are the signs of liver failure that you traditionally study? This palmar erythema, Dupuytren's contracture, then this fetor hepaticus, then gynecomastia, breast atrophy, spider neve, spider angiomas, then testicular atrophy, loss of secondary sexual characters and testicular atrophy. That is a sign of hypoandrogenism. And we didn't talk about that parotid enlargement, isn't it? So many patients with cirrhosis may have a bilateral parotid enlargement, which will be more symmetric. We have seen that already. I think in Sjogren's syndrome, I told you this point. And yes, in the hand and nail, we didn't talk about the flapping tremors, asterisk 6. Asterisk 6. Asterisk is again a non-specific symptom, which can be a sign of liver cell failure or maybe due to carbon dioxide excess, like CO2 narcos also you can see asterisks. So many other conditions can produce asterisks. But asterisk is one important point to notice. It's a sign. It's like a negative myoclonus. Myoclonus is typically positive, but it can be a negative myoclonus also. That is asterisk. So that's called flapping tremor. So many signs are there. I might have missed out some findings, but nevertheless, these are not important at all. Everyone will know that. Even a final year student knows everything of this. So there's no point in telling again and again and emphasizing and stressing on all these points. Fine. Apart from that, there are few things that we typically need to know as far as investigation is concerned, because investigations can show anything. I'm going to look out for the etiology. That's the most important. Whenever a patient is coming with chronic liver disease or cirrhosis, first I need to know the etiology. History is very important, where alcohol intake is crucial. And at the same time, how much alcohol they're taking is also crucial, because they might or may not have alcohol-related liver disease. That's why. So again, if they're taking beyond a cutoff, which we'll be discussing in some time, you can call that as significant. But if they're not taking beyond a cutoff, you have to exclude other causes as well. But nevertheless, the one important investigation that I'm going to do is LFT. So see the pattern. So it can be completely variable. At the same time, I need to look out for the, you don't do this investigation. You do serum protein electrophoresis. What you will see? You will see a decreased albumin. That's what you're going to see. And at the same time, you will see increased globulin fraction, especially gamma globulin fraction will be increased. That is the relative increase. This is what we refer to as a reversal of age ratio. This can be seen in many alcoholic patients, especially chronic liver disease patients, where they might be asking this reversal of age ratio. Why you see reversal of age ratio? That is because albumin is the dominant protein, but that is produced by the liver. That will be reduced, but there will be a relative increase. I'm not telling the globulin will increase. There will be a relative increase in globulin with the decrease in the albumin. That's what you see in the serum protein electrophoresis. That can be seen in the normal LFT itself. You don't need serum electrophoresis for that. So this is what we refer to as a reversal of age ratio. This can be seen in many other conditions also, like chronic inflammation also can lower the albumin. Chronic inflammation can increase the globulin as a compensatory response. So this reversal of age ratio and low albumin with high gamma globulin is not a specific feature of cirrhosis or any chronic liver disease. It can be seen in many other conditions. And I need to do the PTINR because I need to see whether the patient is having coagulopathy or not, because it's a sign of a liver cell failure. And number 3, when I do a complete blood count, one thing that is extremely common in patients with liver failure and chronic liver disease is thrombocytopenia. The most important reason for this thrombocytopenia is hypersplenism. Because many of these patients with liver disease will have portal hypertension. Because of portal hypertension, they will have splenomegaly. Because of splenomegaly, they'll have hypersplenism. Hypersplenism means they will sequester a lot of blood cells within the spleen, resulting in low blood cells. So one of the main blood cells to be affected is platelets, where platelets will be sequestered in the spleen, resulting in thrombocytopenia. But remember, even though thrombocytopenia will be there, but usually platelet will be more than 50,000. It will not fall below 50,000. In cirrhosis patient, if it falls below 50,000, it's something wrong. There is something else that is going on. Usually in cirrhosis, even a completed liver failure, your platelet count will not go below 50,000. It will be usually above 50,000. It's unusual to have platelet count below 50,000, even in a patient with a severe cirrhosis. Plus or minus, they can have a leukopenia. Plus or minus, they can have anemia also. These are other consequences. And as far as peripheral smear is concerned, the most common finding that you see in the peripheral smear is macrocytosis. One of the most common cause of seeing a non-megaloblastic macrocytosis in the peripheral smear is liver disease. Apart from alcohol is the most common reason for developing macrocytosis. But apart from that, disease causing macrocytosis, non-megaloblastic cause, it's always liver disease only. And they can show other kind of problems like spur cells. You can see target cells. So many problems are there that you can see in the peripheral smear. These are again non-specific, does not point to it's a liver disease. Ultrasound is extremely important. Points in evaluating a chronic liver disease. Typically in ultrasound, if the patient is having cirrhosis, then you will have some specific findings. Like for example, you will see a nodular liver surface, nodular surface of the liver. You might, plus or minus, is not always true, but you might see a reduced liver span. Size of the overall liver will be reduced. And plus or minus, you can see a relative hypertrophy of caudate lobe. Relative hypertrophy of caudate lobe, and at the same time you will be seeing atrophy of the right lobe. Atrophy of right lobe. But in exam, remember, don't get carried away by this point. If you see this hypertrophy of the caudate lobe or caudate lobe enlargement, in exams it usually goes towards a Budd-Chiari syndrome. But in reality, this is a non-specific finding, can happen in any patient with cirrhosis. But in exam, whenever they give this hypertrophy of caudate lobe, your answer should be Budd-Chiari syndrome. That's the usual thing in exam. But nevertheless, it is very non-specific finding once again. And the loss of structural homogeneity will be there. And there will be areas of different echogenesis. So liver will become more heterogenic echoes. You will no longer have homogenic echoes. In the sense, like different areas will show different echoes. That is again suggestive of a chronic liver disease, and that's again suggestive of a cirrhosis, which means different areas are showing different nodules, and these nodules will have different echoes. That heterogeneity is again a feature of a chronic liver disease. So in reality, the two things I see when I see an ultrasound, for example, I'm doing ultrasound in ICU, a point of care ultrasound, or even if I do a real-time ultrasound and I sit in front of the sonographer, or if a radiologist is doing an ultrasound, what we generally see is only these two things: that heterogeneity of the liver and nodular surface of the liver. That's all. When the liver is more heterogeneous, more showing irregular nodular surface, it's a chronic liver disease by default, and the patient may or may not have cirrhosis. Cirrhosis is more of a pathological finding. Loss of liver architecture with fibrotic areas is what we call as cirrhosis. But nevertheless, how can we tell it's cirrhosis until you see that pathology? We don't do liver biopsy. So whenever there is a nodular surface with the heterogenic echoes, plus or minus if they have a low span, we call it as CLD or a cirrhosis. That's how we make a diagnosis usually. And one more thing by ultrasound that we can do is portal vein Doppler. That's very commonly performed test again. As far as portal vein Doppler is concerned, why we do that? To see the portal vein diameter. If the portal vein diameter in Doppler, if it is more than 1.3 centimeter, that is suggestive of a portal hypertension. This is a question exam. Portal vein diameter more than 1.3 centimeter. Plus, we see the flows also. Reversal of flow in portal vein also is suggestive of a severe portal hypertension. So flows also can be seen. But nevertheless, the portal vein diameter is very important. If it's more than 1.3 centimeter, that is suggestive of a portal hypertension. Plus, ultrasound can show ascites, can show splenomegaly. So these are other findings that I can look for, which are signs of portal hypertension. Signs of portal hypertension. Clear. Fine. Apart from that, we have many non-invasive testing are there to tell it's cirrhosis or not. Because cirrhosis cannot be concretely diagnosed with ultrasound, we have some other investigations where we can measure the liver stiffness, because by default, by definition, cirrhosis patients should have increased liver stiffness because of the fibrosis. So there are some other techniques that can tell whether the liver stiffness is altered or not in chronic liver disease and cirrhosis. One is called as strain elastography. Then we have something called ARFI, that is called acoustic radiation force impulse training imaging. So ARFI is there. So these are the two modalities that uses strain type of imaging. Then there is another different group of modalities called the shear wave imaging, where you have something called PSW, that's called a point shear wave elastography. Then you have a 2D shear wave elastography. Then you have a 1D transient elastography, one-dimensional transient elastography. So these are the techniques that uses something called a shear wave imaging. These are techniques that use shear wave imaging. But even though I told you so many different modalities here, the most commonly used in India right now is the one-dimensional transient elastography, that is also referred to as something called as a fibroscan, which is commonly available in so many centers right now. That's what we refer to as a one-dimensional transient elastography, so which is also referred to as a fibroscan, which is a type of a shear wave imaging. So as per the transient elastography or fibroscan, if the liver stiffness is less than 6 kilopascal, it is supposed to be normal. If it is going to be more than 7 kilopascal, it tells you a probable fibrosis. If it is more than or equal to 11 kilopascal, it tells you the patient is having a cirrhosis. And these values on fibroscan is more applicable for patients who are suffering from viral hepatitis compared to other causes. It's more reliable to viral hepatitis. For alcohol and all, it will not be that useful, but it's extensively related for patients who are suffering from viral hepatitis. In viral hepatitis patients, again, routinely doing a biopsy. Again, liver biopsy is a complicated procedure and itself has a lot of complications. The patient won't agree for a liver biopsy routinely if you do 6 months once. That is why we need these non-invasive investigations to know whether the patient is progressing towards cirrhosis or not. And to know whether the patient is having a cirrhosis or not, the only recommended investigation is biopsy only. But since we can't do that, we are relying on some non-invasive investigations. In India, currently for viral hepatitis patients, routinely they do a fibroscan. So once you do a fibroscan, anything more than 7, it tells you a probability of significant fibrosis. If it's more than 11, surely it's likely to be a cirrhosis. But nevertheless, the line between a CLD and cirrhosis is something which cannot be really delineated. It's very, very difficult. Very, very difficult. In reality, the only like confirmatory investigation to tell whether it is a chronic hepatitis or a cirrhosis, what is the stage of chronic hepatitis, once again is biopsy. That's the only gold standard. But all these investigations, it's very difficult to differentiate. You cannot really differentiate. That's the most important point. I think you can understand. So what are the important points here? So from the clinical to the laboratory to the 1D, transient elastography, which you have discussed already. And apart from that, we have some classification systems for chronic liver disease patients and cirrhosis patients. Of course, I told you whenever you call about CLD, you talk about cirrhosis also, because we cannot differentiate unless and until we have a biopsy. So to whether it's a CLD or a cirrhosis. But both are integrated and clinically we see both of them as a similar entity only. But nevertheless, so what do you mean by a CTP score? That's called the Child-Turcotte-Pugh score, which is one of the commonest scores that is asked in exams to tell whether the patient is having a child A, B, or C, to tell the prognosis of the chronic liver disease. In that, we have 5 factors. One is called albumin. Second is called as bilirubin. Of course, bilirubin will come almost everywhere, the total bilirubin especially. And INR, that is coagulopathy, then encephalopathy, signs of liver cell failure, and finally, ascites, which is a sign of portal hypertension. In this, albumin and bilirubin are signs of liver cell dysfunction. INR and encephalopathy are signs of liver cell failure. And ascites is a sign of portal hypertension. That's all. Remember, there are 2 things that are very important in this. Albumin and bilirubin are the most important. INR and encephalopathy is important as a sign of liver cell failure, but the 2 independent markers of prognosis, even if the patient don't have liver cell failure, is albumin and bilirubin. They play a very, very important role as far as liver disease is concerned. I'll talk about that more in hepatocellular cancer, where you have something called the ALB score. So that's why in hepatocellular cancer, you have something called ALB score, which is based on albumin and bilirubin. These are 2 independent markers of liver cell dysfunction, irrespective of whether the patient is having failure or not. So these are markers of failure, all right, but albumin and bilirubin are markers of independent markers of liver cell dysfunction, irrespective whether the patient is having liver cell failure or not. That's why these 2 are more important in many patients compared to the other values. So nevertheless, you have different values based on the patient's laboratory results. Like for example, you can give 0.1, 2, or 3. So if the albumin is more than 3.5, it is 0.1, 2.8 to 3.5, it is 0.2. And if the patient is having anything less than 2.7, or anything less than or equal to 2.7, we call it as 3 points for that particular patient. We give 3 points to that patient. Bilirubin less than 2, 2 to 3, and more than or equal to 3. And INR less than 1.7, less than 1.7, or 1.7 to 2.3, or more than 2.3. And as far as encephalopathy is concerned, only no, 1 point means no encephalopathy means 1 point. Patient is having mild to moderate encephalopathy. That is 2 points, especially grade 1 to encephalopathy. If the patient is having severe encephalopathy, defined as grade 3-4 encephalopathy, it is 3 points. And if about ascites, if the patient does not have ascites, they will get 1 point. The patient is having diuretic responsive ascites, that is the patient who is having ascites but diuretic responsive. This is called mild to moderate ascites, that is grade 2. We'll give 2 points to them. If the patient is having diuretic resistant ascites, severe ascites, not responding to your diuretics, so that is that patients will be awarded 0.3. So you have 3 points here. Based on that, what is the thing? You can give total points. The total point in CTP score will be 5 to 14. So this is the total, 5 to 15. This is the total score. Please remember, it is like Glasgow Coma Scale score only. The minimum score is 5. A patient cannot get a score of 0. The patient has a good albumin, low bilirubin, normal INR, no encephalopathy, no ascites, will still get a score of 5. It doesn't mean that the patient is having a score of 0. You cannot have a score of 0. That's one thing that you need to know. Depending on that, if the patient is having a score of 5 to 6, they will be put under child class A. Patient is having 7 to 9, it will be put under child class B. The patient is having 10 to 15, it will be put under child class C. So based on the traditional model, if the patient is under child A and having a chronic liver, please understand, if you use the score for me, I'll be getting a child class A. Remember, I'm the one here. I'm not having any liver disease, and you are using the child score for me. I'll be coming under this. So still I'll be getting a score of 5. Based on I'm getting a score of 5, still I'll be under child A only, which means use this score only for patients who are having a chronic liver disease. Don't use this score for patients who are not having any liver disease. That's a very important point. So if you use for patients who are not having chronic liver disease, then everyone by default in the community will come under child A only. So that's not the case. So we don't use. So I mean, that will you be helpful in understanding one important thing, but child A usually will observe. And medical management only. We don't want to really treat very aggressively. So we're going to just give medical management and reduce the risk factors and give an appropriate treatment. Suppose if it's a viral hepatitis, give antiviral drugs. So that's what we're going to do. As far as child class C is concerned, we are going to use only palliative care, which means these are very frail patients, advanced liver disease. There's no point in giving any aggressive interventional protocols. These child B patients are the ones who can be given medical treatment, plus or minus they are best candidates for orthotropic liver transplantation as well. So these are the best candidates. These are the highly suitable candidates where you can take the patients for OLT. It will be the best suited. They'll not be so good like child A patients also. They'll not be so frail like child C patients also. They'll be somewhere in between. So this is the place where liver transplantation can be done in a very good way. So that's why OLT is best considered in patients with child B compared to that of child A or child C. Child A, it's too early to do a liver transplantation. Child C, it's too late to do a liver transplantation. Child B, optimal to do a liver transplantation. So typically, if you ask about the 1 year survival rates, in child A, it's typically 100%. Definitely they won't die. Child B, 80%, and child C is only 40%. 2 year survival rates, it's still 80 to 100% in child A, 60% in child B, and only 35% in child C. So these are the survival rates. Again, the survival rates will depend on the child classification, whether it's CTP, A, B, or C. Then we have something called a MELD scoring. Again, currently more than child classification, we use the MELD scoring for allocating the organs for transplantation. MELD is extremely important. So there is some formula for MELD, which typically tells you 3.8. This is a computer calculated formula, so no need to mug up this. 3.8 multiplied by logarithm of, that's an exposure logarithm. That's why we call E. Serum bilirubin, that's a total serum bilirubin in milligrams per deciliter. Plus we use 11.2 multiplied by exponential logarithm of what we have, something called as INR, plus 9.6 multiplied by exponential logarithm of serum creatinine in milligrams per deciliter, plus 6.4. So this is what we called as a MELD score. So what you will be getting as a question in exam is, what are the factors that are used in MELD score? One is serum bilirubin, INR, and serum creatinine. So one of the important problems with child classification is they don't use serum creatinine, they don't use sodium, they don't use, these are very important as well. These are very important prognostic factors in liver disease patients as well. So they don't use these kind of important prognostic markers. So that is why we have a MELD score. As far as I told you, none of the prognostic markers will not include serum bilirubin. In the sense, like every single prognostic marker will have serum bilirubin. So without serum bilirubin, no prognostic score or nothing will be there, because I told you serum bilirubin is extremely important. So that is the one that depicts the prognosis. So even more than that of the albumin. So every prognostic score will have total serum bilirubin. So you can blindly go for that. And apart from that, second thing that it includes is INR. And the third thing that includes the serum creatinine plus 6.4. There are scores that have something called MELD sodium also, which includes sodium as well. Currently, some people use the MELD sodium also, which includes sodium along with it. That is something easy to predict. But in exam, the question what you're going to get is, what are the markers? I mean, what are the factors, variables that are used in MELD scores, bilirubin, INR, and serum creatinine. I used to remember by a mnemonic called as CBI. That's the mnemonic I use because a very commonly asked question in exam. That's why I used to remember by a mnemonic called CBI. But even though I don't like the mnemonics, you can use this if you want. So creatinine, bilirubin, INR. That's all. So that is CBI. And there are a lot of things that you know about the MELD score, but I'm not going to talk about that. In pediatrics, you have one more score called as a PELD score also. That's called a pediatric end-stage liver disease score. Here it's called model for end-stage liver disease, but in pediatric, you have a PELD score separately. But nevertheless, MELD score is the one that is used for so many conditions right now. For example, this is the one that is used to give organ allocation in patients who are suffering from end-stage liver disease and who are wanted to go for a liver transplantation. Organ allocation system is actually based on MELD score only. And majority of the treatment options is also currently based on the MELD score only, especially when to do a TIPS, whether TIPS will be effective or not, or when to move from TIPS to organ transplant. So many things are based on the MELD score. So that is why the MELD score is the one that is currently more important compared to the of the Child-Turcotte-Cook score. But that's why it's important to know as well. And at the same time, the final thing that I wanted to tell is, what are the hormones in cirrhosis? What are the hormones that are increased in patients with cirrhosis? And what are the hormones that are reduced in patients with cirrhosis? This could be a question. So there are some hormones that are increased in cirrhosis like renin, noradrenaline, and antidiuretic hormone. So remember, this is very, very important. So one of the main reasons for hyponatremia in cirrhosis patients. So these are three hormones that are increased in patients with cirrhosis and liver failure or a chronic liver disease, doesn't matter. So what are the hormones that are decreased? The most important hormone that is decreased in patients with cirrhosis is cortisol. Very, very important. And again, a multiple times asked question. Hormones that are decreased in cirrhosis is cortisol. Clear? So I think I've told you so many points in cirrhosis as well. So the final take-home point here is causes of cirrhosis that is common in India, cause of chronic liver disease that's common in India, and CLD and cirrhosis, usually we take it as a unified entity in India, I mean in any clinical practice, but always you need a biopsy to differentiate them. But nevertheless, but for clinical practice, you can take as a unified entity, not a problem at all. And etiology, we spoke, macronodular cirrhosis, we spoke, clinical features of chronic liver disease, cirrhosis, and some signs of liver cell failure I've shared here. Then what are the different investigations, the reversal of age ratio, thrombocytopenia due to hypersplenism, macrocytosis as a very important peripheral smear finding, and ultrasound, that portal vein diameter more than 1.3 cm, hypertrophy of the cardiac lobe with atrophy of the right lobe, and that transient elastography called as fibroscan, where the more than 11 kilopascal tells you it's cirrhosis, Child-Turcotte-Cook score, albumin, bilirubin, INR, encephalopathy, ascites, and MELD score, which uses creatinine, bilirubin, and INR as the three important variables there. And hormones that are increased in cirrhosis, most important is ADH, that is increased, and most important hormone that is decreased is cortisol. So this is the take home from this particular session. I think this session is useful. I'll come back to you. We'll be discussing about the portal hypertension and other problems due to portal hypertension in a short while. Maybe day after tomorrow, we can start the session. Till that, stay tuned. Bye-bye. Good night. Thank you, Ankit. Bye-bye. Next session, I'll inform you. So when to take. Anyway, we'll be completing. I'll show you. I mean, I'll tell some short introduction to RS, endocrine and all. Not a problem. But nevertheless, I'll keep continuing hepatology. Hepatology is very important for exams, especially next session will be on portal hypertension. After that, it will be on hepatitis viruses, which is very important. And after that, we'll complete our discussion on hepatocellular cancer, and that will complete hepatology. So portal hypertension, hepatitis, and hepatocellular cancer. Maybe we can discuss about differential diagnosis of metabolic liver disorders like Wilson disease, hemochromatosis, differential diagnosis of autoimmune hepatitis, PBC, and PSC in a single chart. I will give you everything, not a problem at all. So that all should take only half an hour, 1 hour maximum. So portal hypertension will take time. Definitely viral hepatitis will take time. But I think metabolic and autoimmune hepatitis, PBC, PSC will take only maybe hour or 1.5 hours. Then finally HCC should take another half an hour. That's all. Apart from that, everything must be simple. So we'll complete it in a short while. Maybe in another 3-4 days, we should be able to complete hepatology and GI. So I think after that, your discussion will be complete at least for this year, which means you already got 3 chapters in your app. Along with that, this 5 chapters should complete your discussion on medicine. But still, there are people who have bought only for Express. For them, I'll do some short discussions on RS, endocrine, and a little bit of maybe hematology if possible. But RS and endocrine, surely I will do. Thank you. Good night. Bye-bye.